Ladies and gentlemen, dear colleagues, distinguished invited speakers, dear colleagues here in the lecture hall, and I've just noticed that there have been registered online additional more than 500 people. So as well, welcome to all the people online. It's a great pleasure to welcome you to the Robert Koch Institute, to the Robert Koch Colloquium entitled Empowering Public Health from Data to Global Health. The colloquium is our annual interdisciplinary lecture series here at the Robert Koch Institute. Each year, the colloquium highlights topics of growing importance to the public health community, and we invite leading international experts in the field to present and discuss their area of work. We aim at an interdisciplinary exchange and look forward to establish cooperation for future research. After last year's colloquium on the mobility of pathogens and people and its impact on public health, we chose this year another complex and challenging topic, increasingly impacting both society and our scientific field. Indeed, within the global context of digitalization, public health is forced to adapt and transform rapidly. Over 2 days, a series of lectures will address topics related to data generation, data application and usage, and the international exchange of data. Today's presentations will showcase the advanced status of digitalization and health data in Denmark and its importance for public health preparedness. Afterwards, we will focus on the generation of public health data, where possible biases may occur, and where biosensor-based data from wearables devices offer new possibilities in health monitoring programs. The last presentation today will display the application of the generated data for the modeling of infectious disease dynamics of emerging threats and epidemics. The transformations in data generations and data usage are impacting every public health sector and their interdisciplinary collaboration. Tomorrow morning, you will first hear about the effects of digitalization on public health microbiology. Then we will learn about methods applying artificial intelligence for systematic reviews. And the last 2 talks will present the interdisciplinary applications of data for One Health preparedness and global pandemic and epidemic intelligence. Finally, all the presented diverse topics and ideas will be rounded off through a panel discussion that will take place tomorrow afternoon. The discussion will be on the future of data-driven public health, as well as the induced opportunities and challenges for local and global health. I would like to thank the speakers for their willingness to contribute to this colloquium. And of course, I would like to thank my colleagues from the organizing committee who put great effort in designing this conference, in addition to their normal duties and daily work. For now, I welcome you all very warmly at the Robert Koch Institute and look forward to hear and learn from the excellent speakers and contributors. I hope you will enjoy an exciting and productive exchange. And with that, I would like to introduce our keynote speaker, Henrik Ullum. Since 2020, he is the director of the Statens Serum Institute, our Danish counterpart. His institute has a long-lasting story with ours, as it was founded 11 years later in 1902. And moreover, Fritz Kaufmann, a Jewish scientist who was dismissed from the Robert Koch Institute in 1933 because of his origins, was later employed at the SSI. And until now, a famous Danish research prize is named after him. That is given by the SSE. Professor Ullum holds a medical degree from the University of Copenhagen, where he has worked as the head of the biobank and the virology section between 2006 and 2020, and became a professor in 2014. He will give a talk about digitalization and health data in Denmark. Thank you for accepting our invitation. We are very much looking forward to your talk, Henrik.
Yes, and on my side, I will say thank you very much for the invitation and thank you very much for the kind introduction. And as truly mentioned by Professor Schaade, there is a very, very strong collaboration between Robert Koch Institute and SSI, and that has been going on for many years, and I think we are all dedicated that should continue like this. So the issues of my talk are, I'll start to briefly introduce you to Statens Serum Institute. Then I will talk to you about how we use health data in general, what are the general principles behind how we use health data. Then I will focus a little more on what we learned during COVID-19, what was the lessons learned during COVID-19, how specially did we use data during COVID-19. After that, I will broaden up further again and mention what is happening with healthcare data in the broader sense right now in Denmark, what are the challenges in the future. And then at the end, I will refocus back on epidemic surveillance and take a look into the crystal ball and talk a little about what I think will happen in the future and what are the issues that we at least are working on at SSI. So briefly about Statens Serum Institute. Wow, a little too fast. So as mentioned, it's an old institute, not completely as old as Robert Koch, but inaugurated in 1902 when Copenhagen was facing severe epidemic of diphtheria. There was a mortality of about 50%. Some of the first clinical trials were performed in Copenhagen showing that you could halve that mortality if you treat it with anti-diphtheria serum. And therefore it was decided, okay, we want this serum therapy also in Denmark. Of course, very soon the focus moved from serum therapy to vaccine research, and for many years a lot of vaccine research was going on, and we were one of the first countries to make polio vaccines, also have successful developments of diphtheria, tetanus, and tuberculosis vaccines that were produced and sold around the world. From that start, the focus broadened. So just and it's a situation very parallel to Robert Koch. So we also had the responsibility for epidemic surveillance, and later on also for being the reference lab for infectious diseases. And then further on, we have had the responsibility to biopreparedness for congenital screening of newborns. And for the last 15 years, we also host the National Biobank of Denmark, where we have about 13 million samples of 6 million Danes. Again, during COVID-19, just like in previous epidemics, suddenly SSI became very, very obvious in the Danish public, and our roles were very similar to the Robert Koch. So we did surveillance, risk assessments, mathematical prediction modeling, counseling, research. And then in Denmark, we also have the role of being the national vaccine supplier. So we purchase all vaccines and distribute them. And also one major difference during COVID-19 between us and Robert Koch is also that we put up a very, very large testing scheme. So at the peak of the pandemic, we could test 200,000 PCR samples per day. That means that each day we could test 1 out of 30 Danes by PCR, which is quite massive. And similarly, also we put up a very, very large sequencing capacity. So throughout most parts of the pandemic, we could actually sequence all samples, which was important for the information on what happened in the pandemic. So who are we today? We took the learnings from COVID-19, and I think the learnings in Denmark, very much like the rest of the world, was that we were not really prepared for what hit us during COVID-19, and we have decided we want to be prepared and agree with that with the Danish government. So right now we are very much a preparedness organization where we have large-scale testing, large-scale sequencing as some of our core competences, but also the way the world looks right now politically and militarily. We also have a broader focus on preparedness. And for instance, some of the dashboards we thought we would build strictly on infectious diseases, we are right now taking a broader scope on these dashboards and seeing if they could use also for other preparedness situations than infectious diseases. Then we are a One Health Koch-Institut, and I can say we are truly so, because for a long period we of course have been the human reference lab in microbiology, but for the last 7-8 years we also been the veterinarian reference lab, and that means we have veterinarians and medical doctors working closely together, which is very advantageous, because as we all know, a lot of the infectious disease threats that are out there, they are moving between animals and humans, with flu as a big example, and similar with COVID-19 as another big example. Then our role is again very, very similar to the Robert Koch. So we see ourselves both as a research organization and as a strong public health institute. And just like here, to integrate these two functions is important, because we think we can be a better public health institute when we base all what we do on research. And to be honest, sometimes I'm challenged by the Ministry of Finance and our Ministry of Health and say, why, Henrik, this research is too expensive. And then I mentioned Robert Koch as a shining example. We need to do it like this. That's the way to do it in international public health, because that's how you reach the highest competences. So I hope you will stick to that strategy as well. So I can have you as a backup when we are challenged. Yes. So now a little closer to the exact focus on today, on how we use health data. And actually, this very first simple drawing shows you most of the important things that I'm going to talk today. So, of course, every testing and every surveillance start with the patients, and we do that very similarly in Denmark as in Germany. Samples are taken or cell swapped or whatever has happened, and they go to a microbiology lab. And then in Denmark, we are quite lucky, because someone back in the late 60s in Denmark decided it was too complicated, that we did not exactly know who each Dane was. So he invented something called the Central Personal Registration Number. That's a number with your birth date and then a 4-digit after number, and that can identify anyone. And that means any sample or any other diagnostic test can then be linked to that. And with that goes into first the clinical labs databases, and then it feeds into one of the big databases that we host at SSI, the Danish National Microbiology Database. And no matter if it's a private or public lab, or if it's a primary or secondary sector, all microbiology results needs to go into that by law. And now the smart thing starts, because then from there, that's actually where the clinicians, they can reach these data. So when we build these kind of systems, we make sure that they benefit not only our surveillance, but they have to benefit the patients. And you can say, well, you can do that just at the hospital. Yes, but we all know that patient, one day they're at one hospital, then they move or they are transferred because they have complications. And we want to make sure that these data, they follow the patients along. And no matter if the clinicians we see here is in one hospital or in another hospital, they should see these data. So that's one primary purpose. Another primary purpose is that the patients or the citizens themselves, they should also have access to these data. So they can have that by their computer or by their cell phone. And especially during COVID-19, we developed designated systems that would make sure that everyone could see their data very easily. And then the smart thing is that on top of this system, which is actually built for patient benefit, we can build our surveillance and our research and dig into that and combine that with other data, combined together with this Central Personal Registration Number. And the good thing is that since this Central Personal Registration Number has been there for so long, everything happening in our little society is coupled to that number. So that is everything happening in the health sector. If you need reimbursement for your medicine, if the hospital needs money for the therapy they give, if the general practitioner need money for what they do, but also in the social sector, in the educational sector, it's the same system that links together. And that means when we do our surveillance and our research, we can pull data in from so many different sources, not limited to the health sector, but also to other sources, because we know, for instance, a lot of health issues, of course, has a social side, educational side, and these data we can pull in as well. And here on this slide, I've shown you some of the data that we use often, but the data available out there is much more than you see here. Some of them are made in bold, and these are the data that we produce in this Danish national ecosystem. So that's the microbiology results I already mentioned. We also have the national vaccination database, and then we have the neonatal screening data and the data from the national biobank. But I'll focus on the microbiology and the vaccination here today, because that's the topic of the day. And of course, the advantage of these data is very much that we can do this circle of surveillance and public health, the circle of prevention. So we start down here at the left, and we are able to pull in all these data for our daily surveillance. And you can see we combine laboratory diagnostics with active notifications of notifiable diseases. Strategically, we are moving more and more from active notifications into lab-based notification. And the reason why we do that is it's more complete. So we are not reliant on, okay, I need to remember to report this. But it's more efficient, because then we don't need to bother the clinicians to put in extra information if we can pull that out of the patient files, and if we can base our conclusions on lab diagnostics. And then, of course, we can add additional data. Mark Stegger here today, so he's responsible for all our sequencing data, and we can pull that into, and it can be combined into that, and then use that in epidemiology. And then at the end of it, of course, the idea is that all this surveillance needs to come into intervention. And this is, of course, what we do in our daily life, just like you in disease outbreaks. And also, I think there was a really strong experience in COVID-19, where we had a very, very fast turnover of data. So we could produce a sequence in very few days. And therefore, we could make a system where from we saw something in the epidemiological data on COVID-19 into political action, this would normally be a matter of days, or at least just a week or two, which was extremely important. So important in the way we build it is that we have one coherent flow of all these data. So you can see it here, starting with someone requesting the data and having a digitalized requesting system. A sampling system where the patient sample is uniquely identified, feeding into different lab systems, typically in Denmark organized in the health regions. We have a public health system. And then from there, feeding back to the clinicians, who can then take responsibility of the patient care. And there we have the MIBA, the National Microbiology Database, where we combine things and where we can then pull in these extra data. And with that, we can feed that into different outputs for research and for advice of the government. But also, as mentioned, the data will then flow back to the patient so they can see their own data, which is, so again, here we see the triangle for patient care, clinical care, for surveillance and research, and for the citizens themselves. During COVID-19, this system was greatly expanded. So we had a very, very big community track testing, and also test systems where people could decide themselves if they wanted to be tested. Normally, there would be a requester saying, does this patient need a test or not? But during COVID-19, this was more open, and everyone could get their test. And now a little to the other major database that we hold, the Danish vaccination register. And again, this system is designed so it can both solve practical problems and it can be used for surveillance. So the vaccination register is smart because people doing the vaccination, they can see, okay, who is this? They can register the data and see what previous vaccination has this person had, so they're sure they give the right vaccination. And also the patient themselves, they can, okay, if they want to prove what vaccinations they had, they can pull the data out. And then finally, we can use the data for our work. And of course, the most simple would be to look at vaccine coverage. For instance, are there social inequalities, and which there are, as you all know. And when we see that, of course, then we can make intervention and say, okay, this group needs to be targeted more to get higher vaccine coverage. And we do have a very, very high vaccine coverage in Denmark. Then secondly, it's a practical system. So the people that do not turn up for the intended vaccinations, we can send letters through this system and remind them it's time for vaccination of you or of your child. And we can see that doing that, sending these regular re-invitation reminders, we then increase the number of people accepting their vaccination. And then finally, it's important that we can use for research, and I think we did that very effectively during COVID-19. So this includes both effectiveness studies, where we were quite fast to see how well the different vaccines worked on the different new variants, but also on vaccine safety studies. So the rare but very severe side effects on the AstraZeneca vaccine was, for instance, first discovered by Danish and Scandinavian data. And importantly, because at the end of the day, to be successful, this all boils down to the need of public trust. And when we do these kind of things, and we do it very transparently, and people can see their own data, they know what we are doing, and they can in real time learn what we learn, it's actually also important to retain public trust, which I think we were quite successful with during COVID-19 in Denmark. As you can imagine, there are so many stakeholders who need these data. And again, that was very, very obvious during COVID-19, where basically everyone, that could be the worried citizen who was worried about their own or family members' health. It could be organization, private business, or public business. How do we navigate with our organization through the pandemic? Or even to the office of the Prime Minister, who would need to, okay, how do we safeguard this little country in these difficult times? And there we had this simultaneous flow of data, which basically meant that very often the man on the street would have almost the same knowledge as the Prime Minister's office. And again, I think that was important to keep the public trust. So now to a little of the learnings on COVID-19, and as Professor Schaade mentioned, I actually took the position in the middle of the pandemic. So 1 week after saying yes to that position, I was standing like this, and because that was December 2020, and we had exponential growth. And from being an anonymous professor at Rigshospitalet, I suddenly stand on open TV and mention that now we need to close the country because we have an unacceptable growth of infections. So very dramatic for the country, for SSI, but also for me personally. So if we take a look at the epic curve, I think you can see a lot of the experiences that you had in Germany as well. So basically, right away, you can see two waves. You can see a massive Omicron wave, and then you can see the winter wave 2021, which was initially the original variants, and then later the Alpha variant. And you can see this is like incidence, and you can see, of course, the Omicron wave is much bigger, and of course, I was not coupled with the same pressure on the healthcare system. Actually, the healthcare system was more pressed during this period than during this period. Then you would ask, okay, where's the first wave? Which you can see a slight, if you need to focus in here, there's a slight hill there. And the reason why that's so different from the other ones is that what happened in spring 2020 is that we at Statens Serum Institute built Test Center Denmark. This is this high capacity PCR testing system. So suddenly from having no capacity to do this testing almost, we suddenly in this period went into a situation where we from zero surveillance studies know that we identified 2 out of 3 infections. And that's why the Alpha wave is so much bigger than the initial wave, because if you look at, probably they were quite similar actually. And then, of course, in the big helicopter perspective, you can see the three different phases initially where we really didn't have anything to do. Non-pharmaceutical intervention was the mainstay to keep the infection at bay. And then when we had the vaccines, increasing focus on controlling first the infections and secondly the clinical consequences by vaccines. So this was of course not one point change, but as soon as we had enough vaccines, that was a clear change. And then finally at this time point, and you can see we lifted all restrictions in Denmark in the middle of February, and you can see that's a period where we actually had 50,000 diagnosed cases per day. So that meant that more than 1% each day of Danes were infected. And at exactly this time point, we were able to open the society. That was criticized, that was questioned a lot at this time point. But now we're talking about data. The thing is that when we looked at data, we could see two things. One thing we could see is that, okay, we have very limited mortality. We have very limited direct pressure of these patients on our hospital system. That was one thing we could see in our data. We could also see we are reaching so many infections now that if we keep these strong restrictions with quarantine and stuff like that, then the work market will collapse. And indeed, the work market also in the healthcare system will collapse. So the main problem, if we had kept the restrictions at that time point as they were, would be, okay, we would have no healthcare staff. So that's why this decision was taken, and at this time, which was actually at a peak of a wave, and that's an example of how we actually used healthcare data to shape our response, even though it's by direct observation say, okay, that's a blunt move to open your society completely with this number of daily infections. And then above or beside all these three major phases, then we have a million of other things that you can see. I've just mentioned, I will not go through them, things that we need to deal with. But throughout these different phases and these different diseases, we all the time had this system where we had very high diagnostic capacity, very high sequencing capacity, a very quick turnover of data from the lab into the surveillance, and of pulling surveillance data in from the hospital. So we could do a daily monitoring. So all challenges that we were met by during COVID-19, we could more or less do that on a day-to-day basis, and thereby allow the government to take quick decisions. And I think perhaps decisions that in many cases were right. And then, of course, you can see mink is mentioned 3 times. In Denmark, we also had this special challenge with a parallel mink epidemic. In Denmark, at this time point, there was 18 million mink. That meant 3 minks for each human. And with an epidemic among minks that went completely crazy, and we started to see mink mutation moving. That was an unacceptable situation where the whole world tried to keep this infection at bay and to avoid new mutations to occur. So basically, if we take what I think we experienced, you can compare that to driving a car at night, even at night with a little fog. The thing is, initially when we did not have big diagnostic capacity, and we did not have good sequence capacity, and we did not have a real-time system to combine the data, it was a bit like driving a car with far too little light on. And very soon we then built this high diagnostic capacity, the high sequencing capacity, and were able to pull all these data in, and suddenly it was a bit more like driving a car with good light. And then I will not talk about our experiences in mathematical modeling, but we also used mathematical modeling to try to see a little into the future. You cannot see far into the future, but at least what is likely to happen in the next few weeks. And I think that's a bit like adding a GPS system to your car. So you do not only react on what you see, but you also react what the road ahead of you looks like. Good. Then a little on some of the output that we produced during COVID-19. Again, you see on the top here, you see the different data sources. So the National Microbiology Database, the vaccination database, combined with all these national registers. So what we did, like in many other countries, we put them into these dashboards that actually I didn't know what a dashboard was before COVID-19, but quickly learned, okay, this is something we need to build and we need to update. And we were also able to like change the dashboards along the way, so they kept fitting to the questions at the different times. But of course also a big number of scientific reports and reports to the government. But again, importantly, we tried to build the system so it was also for the benefit of the citizens. So we built a lot of mobile applications where they could have their data themselves, both just to know what it is, but of course also to have the Corona passport, and also of course through access through the computer. And it's important to understand, you may ask, why did Denmark choose to test so much as they did? Because I didn't mention that, because on top of these 200,000 PCR tests, we actually built a similar capacity on antigen testing. So then we moved from being able to test 1 out of 30 Danes to 1 out of 15 Danes per day, either by PCR or by antigen testing. It was actually a strategic move because we had mathematical models showing if we apply frequent testing, we can reduce the number of infections. And that was to the political scene a more acceptable solution than having more close downs than we had. So it was a balance to keep the society as open and still have epidemic control. So that was one clear argument. Another argument actually also was when the Corona passport was decided to be needed to avoid too much discussion and arguments about if you need to be vaccinated. It was important that it was you could have your Corona passport free by doing frequent testing, and that should not be too difficult for the population. And being able to do that was important because then people could not be angry, say, okay, I was forced to be vaccinated. I think at the end of the day, a lot of people then got tired. Okay, if you need to be swapped every 2 or 3 days, at the end of the day, even if you didn't love the vaccines, a lot of people say, okay, I'll take it. I'm tired of this. But it was throughout the epidemic possible to be out in society, even if you didn't want to be vaccinated. And I think that was also important to keep trust. So I said that Denmark probably, we did quite well during COVID-19. We have a very low excess mortality. We also came out with a good degree of public trust at the end of epidemic. And finally, actually also the economy was very, very strong in Denmark after the COVID-19. And you can, of course, say there's a lot of factors how you do this. And I think the two most important things are, or maybe the three most important things are here in the top. The starting point was a high degree of public trust. So to do something like this in a society where people trust the government, they trust public institutions, is much easier than if you have distrust. And I think all the Nordic countries did well, and they did that with the basis of this. Then the second was a high degree of political commitment. In Denmark, we were lucky we had a government who was really, really keen to deal with this in an effective way and gave us and other stakeholders the needed resources. And if you want to build something fast and effectively, it's important that you have access to resources. And we were lucky in that respect. And then finally, in Denmark, we had a very, very good cross-sectoral collaboration. And I think that's probably helped that we are a small country, so a lot of stakeholders knew each other beforehand, and therefore found it easy to collaborate together. Then some of the things that even helped us further was the strong digital data infrastructure. I mentioned that this allowed us to completely and fast to combine data and make the conclusion, and also the right conclusions, and also what we built, the high testing and sequencing capacity, which then again allowed us to have a continuous flow of data to all stakeholders, and importantly to the public, and thereby maintaining public trust. So these were some of the main learnings from the COVID-19. Now I'll broaden back a little and talk a little broader on the use of healthcare data in Denmark, and especially what is coming up. So for Denmark and looking at Denmark, it's important to know that Denmark has made a change. Denmark traditionally used to be a farming country. That was the main working and economic business in Denmark. But right now it's actually life science. So life science holds 20% of the Danish export and is similarly important also when you look at what people work with and tax paying, and therefore life science is extremely important to Denmark. Similarly, if you look into scientific publications, of course Denmark is a small country, but if you look per capita, Denmark has a very high ranking in publications per capita. And these two things is recognized by the Danish politicians, and they have an ambition that it needs to stay that way because we need to keep on having a strong life science sector. And therefore we typically have life science strategies that points into the future and show, okay, how can we keep both research and innovation at high stake or at high quality. And I will show you a few of the things that are in the present life science strategy, and of course, especially focusing on things that has to do with the use of health data. So we have a strategy on better use of health data embedded into the life science strategy, and we have built a national partnership for health data. You're not really friends here. Oh, that's how you sit on. And if you look at this curve shows how available data are, and it also shows how much they're used. You might say, well, Denmark, you're on the top of the list. Why would you want to improve anything? And the ones laughing here, they have seen where Germany is, so I'll not. And I'm sorry to bring this slide. I didn't invent it for this purpose. It was there, and so I think we can all agree there's probably room for improvement here in Germany. And just to be honest, even though things look good for Denmark, we are still ambitious in this area. And so now I'll dig into some of the challenges that we have, although that it's easier here than in Germany. So one of the main challenges is that I mentioned all these beautiful data, and I mentioned that we can have access to them all. But the truth is that these data are owned and governed by different organizations. And when you are a public institution and you're in the middle of a pandemic like we were, then you can pull everything and you don't need to ask anyone. But if you just want to do research, you need to go to each organization and explain what you want to do. And they have each different lawyers who may have different ideas of what you can do with the data and where you can put them. And that makes the reality for researchers sometimes quite cumbersome, and the heaven I just described to you may look a little more difficult if you are in the frontline researcher. But we want to change that. So the way we want to change that is to make one future entry point. So you don't need to send it to all these different owners. You just send it one place. And these different organizations, of which we are one, as Statens Institute, we are also one of these data owners. And then we combine the legal efforts. So we make a more harmonized decision and thereby hopefully a faster and less complicated journey for the researchers and surveyors. Then we also, right now, the data can be analyzed in different systems, and we want to bind them together. So it's a seamless system and a system that is coordinated. So if you have access to data here, you can easily move them to somewhere else, and thereby also making a better computational and storage capacity for the data. And not surprisingly, this is supported by the Danish government, but also by the Novo Nordisk Foundation that has a keen focus on the future of Danish healthcare and Danish life science. Another challenge we are facing right now is actually the challenge of being a first mover, because moving into a European health data space I think we have an idea, okay, we probably have all the data that we need to put into European health data space, but the truth is that our data standards, they do not really fit with the data standards that will be developed in Europe, and therefore we need to do a lot of work of translating these data. That will require some work, but I assume it will probably be easier when you have the data to translate them than if you really don't have access to the data. And then there's this whole discussion of public trust. I know that has been a big issue here in Germany, and of course it's also an issue in Denmark. In Denmark, we are quite keen to try to be very transparent of what we do. So one of the things we've done in Statens Serum Institute, where we hold a lot of samples in the National Biobank, is writing out to each individual which samples, which data we hold to them. And that's a way of increasing public trust and also having very transparent the way we work with data. So people that are more skeptical on our work, they at least can see very transparently what we are doing and why we are doing it, and also get informed of, okay, if they don't want their samples to be used in research or surveillance, what can they do to pull the data out, or what are the legal possibilities? I'm coming to the end of my talk, so a little on the what I see as future possibilities and at least things that we are working on or want to work on at SSI. We would like to continue to increase the number of data sources. Right now, Denmark is undergoing a major healthcare reform. That healthcare reform would put a lot of healthcare closer to the citizen. So that would be in the municipalities and in the primary sector and even in patient homes. That would feed, so a lot more data will be created close to the patient. So we want to make a system where we can collect data also from there, whereas we right now have a system which is more fitted to collecting data from the hospitals. So we want to put our data collection closer to the patients. As mentioned, as we are one health institute, we want to increase that. Right now, we are mainly surveying the farming production, but there are other one health environments that are not being surveyed right now, and we want to expand that if we can get to that. We also want to take the learnings that we had during COVID-19 and increase the public participation. We learned that people could easily swap themselves. They would happily give additional information in large-scale questionnaire studies, and we want to increase that. And actually, our pandemic preparedness built on these concepts. So if we have a new pandemic where we need to test thousands and thousands of people, we would not put up swapping stations. We have a system where we can do that digitally, and people can swap themselves and then just have the samples transported to us. So we don't need to use workforce for that, because that was also during COVID-19. Workforce very quickly became a lacking resource, and we don't want to get into that situation again. Then, as mentioned, we are building new dashboards, and now we will also focus on dashboards, not just showing on infectious diseases, but actually trying to depict the day-to-day capacity of the healthcare system, which will be important not only in a new epidemic situation, but also if other threats are hitting our society. Then we would continue. We did some quite large serosurveillance studies. We would like to increase that and continue that, because it's important when we need to know the true case fatality ratio, the case hospitalization ratio, or even how diseases spread truly in our populations. And then finally, we are seeing future wastewater surveillance as an additional data source that supplement our good epidemiological surveillance. And this is something I've been asked several times and always been discussed. Okay, what additional information does wastewater, or in a broader sense, environmental surveillance give you? Well, you can see it in the bottom. It's actually giving some kind of indication of undetected cases. So we saw that clearly when I show you the epi curve when during COVID, during the Omicron wave, when we said, okay, now it's over. We let this virus loose, and also at this time point we very fast stopped testing a lot, And suddenly we were quite unsure at SSI if what is then the number of infections. But we followed the wastewater signal and the PCR positives and saw that they were mirroring each other very well during the epidemic. And therefore, when the testing closed down, we could see, okay, we can still follow the wastewater signal. And I think that's doable for other diseases and also for rare diseases that can perhaps be detected earlier. And therefore, we're also happy that we coordinate the EU WISH collaboration, and I'm really glad that Robert Koch Institute is also part of that. That was what I had planned to say. I don't know how I did on time. I spent too much time, I think. No. Happy to take questions.
Hey, thank you very much for this inspiring talk. I think a lot of us are jealous seeing the Danish perspective. So first of all, my name is Franziska Leier-Nicolaou. I'm from the Infectious Disease Department, and I will guide you to the first part of the day. So there are more than 300 people online. So post your questions in the chat. We will try to answer them. But we will start in our audience here. There are 2 micros around, I guess. And just raise your hand and wait. Hinter dir.
Yes, thanks. Great overview. And we sure looked at Denmark for data for our decision making, that's for sure. But how do you see the balance? Because you managed to ramp up testing crazily. I mean, we were all envious. But in other parts of Europe, we really had shortages of reagents. And so this is also about what do you do nationally and what is European equity. So what is your vision to the future? Should there be maybe a few countries that do, as you said, and say, this is our representative surveillance and the rest goes to a more cost-saving approach? How do you see that?
I think what many countries realize is that once you wanted to expand your testing and if you did that embedded into your existing testing system, you would cannibalize on your existing testing system. And that's actually the exact reason why we built a parallel system. So whereas the clinical testing system was built on a pre-existing platform, very often provided by pharma companies, diagnostic companies, which only had a limited capacity, we deliberately built our testing system on open platforms. And in that era, that sphere, there was no lack of reagents. We used standard plasticware, standard probe and primers, and there was never any lack of resources there. We could even get the automation equipment, so we could apply large pipetting robot. I think if everyone had done what we did, that would probably have been a limiting factor, but that could have been overcome with more manual testing. But as far as reagents and plastic, I don't think there would have been any bottlenecks because we deliberately used open platforms. And I think that must be an important strategy in future preparedness, to have some open, scalable platforms that can be used by individual countries or international organizations, how you want to do it.
Yeah, thank you, Henrik, for your beautiful talk, and of course we are jealous, and that's all working.
You can use this one.
Thank you for your talk, and of course we are quite jealous in Germany, but we try to get better. Although we do it, as always, on the complicated way. For example, we have now an electronic patient file, but this is not centralized. The patient files lie with each of the health insurances, and anybody can choose if we want the electronic patient file, and he can exclude certain diseases from this file if he has one, and he can opt out from research activity. So it's complicated enough. But then just after 1 day, when it was started, the electronic patient file, one of our famous German hacker clubs, the Hamburg Chaos Computer Club, hacked the system and they made a press release and say, well, there's a weakness in the system, and it's may be dangerous for the data security and so on. And this is quite obviously it's a difficult discussion in Germany. So you already mentioned trust, and what's your final recommendation? Don't you have any hackers that try to challenge the system? So it's
Yes, we do have hackers, and I think even we are right now in an international situation where you would even perhaps see that foreign hackers would, for strategical reason, want to hit countries like either Denmark or Germany. So of course that's a threat. And therefore I didn't talk so much about data security as part of public trust, because I mean data losses will mean loss of trust. And I can tell you we have had losses as well previously, not at SSI particularly, but in Denmark. And every time that happens, a lot of discussion appears, and public support drops a little. And as we all know, it takes at least 10 good users and good stories to compensate for one bad story, and sometimes perhaps even more. So these kind of the data security is extremely important. So we put our data in what we consider the safest systems that we can, and we do our best to protect the data. But I cannot say it would be impossible that one day someone will disturb our system.
But this is accepted by the people in Denmark.
Yes, for now, but again, I think because if you ask people, are you worried about data safe? What are you worried about data? For most people, the main worry is, okay, if I'm tested here, or if I have this, can then the next doctor or the next nurse, can they see what? That's actually the main worry of most citizens. And I think, again, when we are to build these systems, that's the message. We want to make sure that you can always get the right therapy with your disease, and we can only do that if the next doctor can see what the previous doctor could see. And then, as surveillance and research, you can put that on top.
Thank you very much. I'm from the department in the Robert Koch Institute that deals with non-communicable disease epidemiology. So I was wondering, I'm not sure, I suppose your institute also has research on non-communicable diseases. How did you actually upscale also data, resources, analysis capacities to really do surveillance of non-communicable diseases? And also, you mentioned dashboards, but what is your strategy to analyze and to actually send out messages, analysis, prognosis out of these data?
The mandate of Statens Serum Institute is on communicable disease and early life disease, or congenital and diseases occurring in the pregnancy. So we don't have a mandate that is as broad as you. So we don't have a mandate saying, okay, you also need to build a dashboard that can predict future of diabetes or cancer or whatever. So we do research in that sphere, but it's not our mandate to make public information in that. So we do not spend so much resources in that area. Sorry. But that being said, of course, the ecosystem I described to you is also very effective to study these diseases. So now I took the starting point in infectious disease epidemiology, which is of course the mainstay of our work. But all spheres of epidemiology, Denmark is easy to work in.
For infectious diseases, what is your strategy to analyze the data apart from dashboards and to out messages for politicians, other stakeholders?
The strategy on data is that right now we have several databases, and they are located on different servers. So we want to centralize all these data, although they have different sources, and we do that to have higher capacity, higher security, and to reduce resources spent on these. And then we simply want to use these data to inform the public and the politicians alongside the best that we can. I think it's very difficult to like you can do that in very strategic areas, but in a general view, I think the information you put out to the general public and to the politicians, in many cases, has to be the same streamline.
Okay, then the last question.
Thank you. And as someone who lived through the pandemic in Copenhagen, I can just say that what you presented was also what I lived. So thanks very much to Denmark. Two quick questions. You mentioned trust a lot, and I'm wondering, having heard from the Danish health authorities that each measure was kind of assessed on the basis of the public health impact, the economic impacts, but also the trust of the population. How did you do that, and what data were you using? And secondly, when you spoke about moving a lot of this data to the patient level, to what extent were you able to use antigen results in your surveillance system for SARS-CoV-2?
Good. The first part of the question, I forgot that now.
Data sources for trust.
Yeah, data, we didn't do that. There was a University of Aarhus, a researcher, Michael Bang-Petersen. He very early in the pandemic started to send out anonymous questionnaires to a randomized part of the population, asking some of the same questions throughout the pandemic. And he actually even got support from the Carlsberg Foundation. So he did that in several countries with the same questions. And there, so we could compare the public trust in Denmark and also in other countries. And therefore we could see, for instance, when the mink situation occurred, public trust dropped. When the NPIs got very severe, and also when the politicians start to be a little like threatening in their wording of what we would need to do, also public trust was reduced. And you could see that very, very clearly from these anonymous questionnaires. So we took that into consideration in tailoring the response. And once again, the second part. Yeah, antigen test, we didn't put that directly in because we all know that both the sensitivity and the specificity is not so good. So the regulation was if you had a positive antigen test, you were supposed to go to have a PCR test, and then the results of the PCR test went into the MIBA database.
Okay, so thank you very much again. So I think okay. So we will switch to our second speaker, and we welcome Dr. Mirja Mittermaier from the Berlin Institute of Health at the Charité. And before returning to Berlin, she was a postdoc at Harvard Medical School. And Dr. Mittermaier is an expert for digital health, and her research focuses on the digital transformation in medicine through the implementation of AI-based support systems in clinical practice. And her talk will focus on the biases in public health data, which is a really important issue, because as more and more people are working with these kind of technologies, it's important to know the pitfalls. Welcome.
Thank you. Yeah, thank you for the kind introduction. Also not a friend of mine here. Now it works. Perfect. So I have no conflict of interests. And as you just heard, I'm a physician, so my main work is on a daily basis treating patients. So I'm a respiratory medicine physician, and I also work a lot at our ICU. And I also hold, as we just heard, a master's degree in biomedical informatics. And my really main aim is to bring AI applications into clinical work and really make sure that AI is supporting us as physicians and also helps to improve patient care. And today we want to talk about bias in public health data. I have two small case studies, but before we talk about data and about bias, we of course need to talk a little bit about AI models. As you all know, the number of published AI models increased extremely within the last 10 years. And it's also interesting, at the very beginning, it was the case that there were a lot of studies, and those studies really never made it into the daily clinical work, because it was just a study setting, and then a lot of issues popped up when you try to bring them into the daily clinical work. And one reason was bias, because those models were not really generalizable to, for example, other hospitals or to other countries. But now we have the situation that more and more AI models are really approved, and that those AI models are like tested, for example, by the FDA. And when you compare, for example, in the year, in October 22, we have 521 FDA-approved medical devices who are using AI, and in September 24, we had more than 1,000, so it almost doubled within these 2 years. Since then, unfortunately, due to the politics, FDA is currently not continue to update this list. And also in Germany, unfortunately, we don't have a list which shows us which AI models are accepted, and this is like, yeah, I hope we get that soon, because it would extremely help when you know which AI models are actually on the market, but currently we don't have that list yet. And then when we talk about AI, there's also the question, when does it become malpractice to not using AI? For example, for breast cancer, when you do mammographies, a lot of women above 50 know that. We know that when the images are assessed by an AI model, the accuracy and the detection rate is much better than by physicians. And what we also, at the beginning, when AI came, everybody thought, okay, AI and humans together, oh, that's probably the best way. Unfortunately, it's not. It's totally wrong. Humans bring a lot of assumption into the decision making, and for most applications, in particular when it comes to radiology images, AI is better. So the question is really, when does it become malpractice to not using AI? And this brings us also to the situation when, or in particular when we speak about public health data, like, does it open up the digital divide? Because if poor countries cannot afford that, or there are not enough data, you know, then we have probably also underserving in specific regions. And then now a lot more publications are coming out discussing different kind of biases which are assessed. The question is then also, how can we mitigate those biases, and how can we even detect that? What can we do? So there's a lot going on. And I also published a paper about bias mitigation strategies. And today I will talk a little bit about what we have here in the paper, and then also about 2 other use cases. I just said that before, when we talk about bias, bringing AI models into application, there are a lot of different things that we have to consider. So at the beginning, of course, we have discriminatory data. This can be historic because some patients probably were underserved, did not have enough access to hospitals. So there's discriminatory data is one big issue. Then the AI algorithm itself can be biased. We're also going to talk about that. And we are not talking about it today, but I really want to highlight that I just said that if we don't apply AI models to specific reasons or to specific populations, then we really enlarge the digital divide. And this is a big issue because then we also don't continue to train our AI models with, for example, underserved population. And this becomes a huge issue. So we really have to think about how can we implement those models, that those models also continue to learn with specific data. No, it goes back. Maybe I use here. Okay, so then the question is, we know that AI suffers from bias. At the end of my talk, we will also discuss how much bias is acceptable and can we even reach a no bias system? Probably not. And then we know there's a lot data now out that, of course, bias particular disadvantaged populations which are already underserved. So then the next question is, how can we improve our data sets and our algorithms that we don't have bias, and how can we really plan our studies to mitigate bias? And now a little bit background about what is AI, because we need to understand a little bit what AI is, to also understand what kind of bias can arise from AI algorithms. So artificial intelligence is not new. It started way back, basically with Turing test. It was kind of afterwards the birth of AI, when we had at the beginning also logistic regression. And so then AI went on, and now we're talking about large language models and large multimodal models. But AI is like really, has a long history. And the question is now also, because AI is such a fancy word, do we really need AI for the most applications? Very often, simple logistic regression also does do the trick. So we really have to question ourselves whether AI is already really needed. But also for logistic regression, we need a solid database. And then artificial intelligence, what is that? So it's basically a very broad term for everything what describes when an algorithm mimics human behavior. So for example, chatbots. Machine learning is part of AI, and machine learning needs hundreds to thousands of data points, but those data points need to be a little bit specific. So that means we need to quantify something. And usually machine learning is also supervised. That means we have a label, and then, for example, we can do a predictive task. Whereas deep learning is able to recognize patterns also in an unsupervised way. That means we have no labels, and the deep learning algorithm itself is able to identify specific patterns in data. Then we are talking more about millions of data, and is then able to identify patterns that are specific, and then, for example, also predict whether a patient has this or that disease, and it can basically anything. I just talked about supervised, unsupervised, and reinforcement learning. For reinforcement, not yet. So supervised learning means I have labeled data points. That means, for example, either data come with a label or I have to give a label. So for example, for X-rays or also for CT images, I have to label the data. But that also means that even here I can start to implement bias, because if I don't label correctly, it's an issue. And sometimes you will probably have for example, ethnies where the radiologists don't have that much knowledge about it. So even there, they can make mistakes in labeling. So there we have to start to think about, is the label even correctly? Unsupervised is, it goes into the direction of deep learning. You have different kind of data, and then the algorithm itself detects features within those data and makes pattern out of it. And reinforcement learning is, for example, self-driving cars. That means the algorithm learns to drive the car. And if the driver then steps on the brake, this is a really strong reinforcement that there is an issue, and then the algorithm starts to learn that. So that is also interesting to think about. What kind of algorithm do I really need for my specific task? Is it the right algorithm? Do I have enough data? And this is very important when you plan your study or when you evaluate whether this AI algorithm is correct. And you also need to understand how was it trained. And here we see a machine learning or AI deployment pipeline. So at the beginning, we always have data collection, data preparation. Data preparation can, for example, include labeling the data or make the data harmonized. We just heard about the EHDS, and it's a big issue with clinical data that the data, for example, are not standardized, they're not harmonized. So, for example, we have lab work, and one has this metrics, the other one has that metric, so we need to harmonize and need to pre-process the data. Data pre-processing can also mean that we do data augmentation, which means, for example, for images, that we turn the images or expand the images, so there's a lot of different kind of possibilities. The next is the model development itself. Even there, we have to question ourselves, is that the right model for the right question, and can we change there something? Then the model evaluation with different kind of metrics. We also have to think about, are we really applying the correct metric? Accuracy is not always the correct metric. And when we deploy the algorithm, there's also the question, is the AI algorithm really deployed at the right place? So are the right persons using the algorithm? Is it used at the right time? So for example, if I want to detect something, we are coming today for an mpox example. So when I try to use it, when the disease is almost like over, it doesn't really make sense. So also from a public health perspective, we need to think about where do we deploy those algorithms, and then how do we monitor the performance over time. The next is also important. When we have an algorithm, we train the algorithm, and after training, the algorithm is trained, and then we can do the prediction. This is like how it worked. Now we also have, this comes on the next slide, continuous learning algorithm, but this is the general thing that we need to understand. We have training, and when we have a data set, usually we split the data set into a training set, into a validation set. The validation set we are using during training, because during training we get different kind of curve and feedbacks, how the algorithm is working. And at the end, we have a test set where we test the performance on the primary data set. But even there, you see testing is then not on extra data sets, which are probably outside of the first data set. So it's sometimes hard to say how generalizable is that AI model. And then what we also have to consider is that we have already trained AI models, and then we have continuous learning AI models. Continuous learning means that all data for prediction tasks are then also used to improve the AI model. And we are talking later a little bit about it. This is a big issue currently, because when you now want to get an AI model, for example, accredited by BfArM, it can only be a static model. It's locked. And this is sometimes an issue because the accreditation process takes a lot of time. Then the model is locked. And for example, for CT images, now you have new CT scans. They're probably working better, making better, more high resolutional images. The prediction, it's very likely will be lower because the model is not trained on it. So this is also where we need to talk about it. Then bias is an increasing concern. We know that. And then the first question is, how can we even detect bias? So we heard now a lot about AI. And of course, when we want to detect bias, we need to perform predictions on subgroups. And when we are thinking back, the first AI models which were published, for example, about sepsis prediction or detection of pneumonia in X-rays, very often it was not published on different kind of subgroups. And this is, of course, an issue because then you only know the overall performance, but you don't know on subgroups. Now it's really changing. So usually when you publish in high-ranking journals, you must publish your performance in different kind of subgroups. But this is the first question what you should ask yourself when you are confronted with an AI model. How is it performing on different kind of subgroups? Then we have a lot of different biases. It starts with the conception of the study, even during data collection, pre-processing, in-processing, post-processing. So there's a lot. It's very hard to understand. And this is why I have here now a few case studies too, where I walk you through what we did. So in 2022, I think all of you know that, we had an Mpox outbreak, and our aim was to develop an app which is able to detect Mpox lesions in patients. And so then we had data, not that much data. So we had 63 images from 12 male patients. So this is not much. And then we also had data from Charité, unfortunately, because of a lot of data restriction and issues, we couldn't use it. So we only could use that data. So with that, can we really build something? Probably no. So what other data do we need? And then we thought about it, that we need a diverse and representative data collection. Sounds good. And so it was also clear that we need that, because if we don't really have that, if we just have like a very small data set, we get a selection bias, and then our algorithm would not work well. So what we thought is when we need a diverse data collection of Mpox data sets, we went into scientific literature, for example, to PubMed, and in open access journal, we found more than 600 different kind of monkeypox images, which we are also allowed to use due to their license, but when it's so we use that. And then we also thought, okay, when there is a patient coming with a lesion, how do we know whether it's monkeypox or whether it's not monkeypox? So we need, of course, a lot of other data sets. And then the question was, what kind of data set should we use? And because AI models started in radiology, also dermatology and pathology, because AI models are very good in detecting patterns in images. We are very lucky because there were a lot of data sets, dermatology data sets already out. And the good thing on those data sets is too, they are like already evaluated with other different kind of AI models. So we know what kind of performance could be achieved on those different models. So this is really helpful. And this is the first hint for you when you're saying, oh, I want to work with AI. Be a little bit creative, think about how you can enlarge your data set, look what is already out there, even when it has at the beginning nothing to do. For example, a data set about benign and malign tumors, skin tumors has nothing really to do with Mpox, but of course it's very important to train your algorithms to, so think about it. And then we had at the end almost 140,000 non-Mpox images and almost 700 Mpox images. And then the next question was, how do we want to train our AI algorithm? Basically, what we wanted is it monkeypox or is it not monkeypox? So it's a binary task, yes or no. However, when you look at our data set, we would create bias in our algorithm. Because for the algorithm, it would be very easy to say always non-monkeypox image. The accuracy would be phenomenal. However, it wouldn't help us. So it does not make sense in this case. So what we did then, that we didn't go for a binary prediction task. Instead, we asked the algorithm, please predict us the skin lesion. So we had in total more than 50 different kind of diagnoses there. So we trained the model to predict the different kind of skin lesions. And of course, we were just interested in detecting monkeypox, but otherwise we would have implemented here an algorithm bias into our algorithm. And this is also what I meant at the beginning. You really have to think about what is your goal. But if you just go very straightforward, you cannot really reach your goal. So you have also to understand how the algorithms work, and it's just mathematics. And when you're getting good accuracy, there is no encouragement for the algorithm basically to detect really difference and patterns, because the accuracy anyway would be very outstanding. And so then the next thing is also selection bias, which you always have to think about, you know, because sometimes people with, for example, darker skin or lighter skin are not included in your data set for a lot of different reasons. So it's always very encouraged that you really make sure that those kind of biases are addressed. And this is here also a table from our work. And we showed how the performance is, for example, male, female, then Fitzpatrick, that are the different skin tones, and also different kind of body regions, because it could probably be that if you have a skin lesion on a different body region, you know, that also could be a bias. Then we also looked at different kind of ethnicities and had a long supplement where we published all the data on those different subgroups. But this is really, you need to think about, we also talked to dermatologists about what makes sense, and also the different body regions are important, because from some body regions, you have less images, and that could also introduce bias again. So you really have to think about how is your data set basically built, and where could an issue arise. And this really means you really need to know your data set, and you really need to understand what's in there, and you really need to think about where could problems arise. And it's always different from a different data set. So what we had then, we were then able to assemble a large data set, basically built on publicly available data sets. And then we also tested validation and testing cohort, and the area under the curve, and all sensitivity and specificity was really, really good and very comparable in the testing set and in the validation set. So at the end, we could also show that our algorithm is very robust, even across different kind of skin tones. And we were very happy because we had an outbreak in the US, a little bit in Germany, but of course also in Africa. So it was really important for us that our algorithm works on different kind of skin tones, and we could demonstrate that it worked. The next thing is, if you want to detect bias, or if you want to mitigate bias, you really need to understand, is the algorithm really detecting or predicting what you think what it's predicting? Probably it learns something completely differently. And one way to show that, if you use explainable AI, and explainable AI means that, so normally AI is a black box. So you have a prediction and you don't know what happens in between and how the algorithm makes a prediction. And if you use explainable AI, there are different kind of techniques where you get explained what are the most important and the less important parts here in an image, which resulted in the prediction. And also when you consider now the EU AI Act, so when you use AI models in medicine, these AI models must be, because they're high-risk class, they must be explainable, because otherwise you don't understand what's going on there. And what we did here is we used SHAP values. What they are doing is they show you when it's blue, that this is a region which is against, which is not in favor of the prediction. So it speaks against, in our case, about being monkeypox, while red is more speaks that this is like monkeypox. And here you see from A to G the different states of monkeypox. It was also like an issue here that monkeypox is not just one lesion, but it has different stages. So we were also curious about how's the performance about different stages. And it was kind of constant too. And this is a way that you can really see, okay, the algorithm learned what is important in our case here for monkeypox. So this is important to also to think about which kind of explainable AI you can establish. And then the next thing is regular auditing and monitoring, because even when you develop that, the big thing is then how can you continue and update your algorithm? This is one thing. And then the very big question is also how is your algorithm working in real world settings, because very often performance is for a lot of different reasons lower. So we also developed an app and also a database and hoped to collect a lot of photos. Unfortunately, we couldn't collect only a few because then the outbreak was gone. It was at that time clade 2b, now it's clade 1, so it's a little bit different. Also, it looks slightly different, so we need to update our algorithm again. But it's very important when you design those models that you also think about when you try to continuously update your model, what kind of database can you use and how do you implement the database? How do you get consent? Do you need consent? It depends, of course, on the region where you do it. It depends, of course, also on the different kind of data which you collect. But I think it makes a lot of sense to really think about how can you continuously update your database. So now case 2, ICU. This is where we're currently working on ICU mortality prediction and prediction of organ failure. And we have different kind of training data, lab results, X-rays, CT scans. There are different kind of scores which you calculate when you come onto the ICU. And then the question is, will the patient die or not, or will the patient develop, for example, organ failure within the next 48 hours? And here again, I'm from Charité, so we have Charité data, which currently we have about 200,000, which we are using, but it's not that much. And then the question is, how generalizable is our database? Probably not that much. So we did here the same again. We looked up other databases, and unfortunately, there are different ICU databases published. For example, Mimics, this is an US database. And they have, fortunately, also FIRE, LOINC, SNOMED, CT, so all these different terminologies which help to standardize our data. They used it. So we also used, we are currently in the process of using additionally to our data, those data, to expand our data set and to make our model much more generalizable. And here the effort, we heard that before, to try to harmonize data, it's so important because as I used, you couldn't even use it. So that also means that you really have to check whether your data are usable. And then the next thing is, this really applies for clinical data, are the concepts the same? So for example, if you calculate PF ratio or Horowitz index, which means that you need two different kind of data to calculate something. And then is really the question, how do you really calculate that? Yeah, so for example, for Horowitz index, what we need is the FiO2, that means how much oxygen is the patient receiving. And then we also need to measure how much oxygen is actually in the patient's blood. And then usually this is not measured right at the same time. It's in the electronic health record, it's at different times. And then the question is, like, for how many minutes, hours away, when those data points are away, how did you calculate that? And these are clinical concepts, and very often those clinical concepts are also not described that well. Also for sepsis, there are different kind of sepsis definitions. And for us in Europe, I think we really need to make sure, and EHCS is working on that also those clinical concepts are precisely described, because when we work with clinical data, it really goes beyond just using data from the EHR, because usually we work with the data and also calculating for how long a patient is mechanically ventilated. Everybody thinks, oh, that's easy, but it's not easy at all, because you start weaning. Sometimes a patient in between went for a CT scan, so there is no data. Then 2 hours later, there's data again. So how do you deal with that? And this is also a coding question. How do you write the code? How do you define it? And it's not easy at all. And this also all needs to be standardized. And then you can compare those data sets. The next thing is what you can do. You could also apply transfer learning when you want to increase your data. Transfer learning means that you train an algorithm on a data set which has not exactly something to do with what you have. So for example, you want to do train an algorithm to detect skin cancer. Before, you can use other large available data sets, for example, with dogs and cats, and train the algorithm to detect dogs and cats, to make so that the network learns to differentiate, for example, corners, edges, different kind of colors, and this also helps. And this could help you when you have not that big data set, but it improves. So it helps you that the algorithm is able to better generalize, and you save training time, and you need a lower data set. That can also help. And then, in particular, when you develop your own data sets, usually, in particular in Europe, everybody should use those FAIR principles. That means at the beginning, data should be findable. I mean, it sounds easy, but sometimes it's, so you need really a unique identifier. They should be accessible. Of course, with clinical data, very often it's not possible because of data restriction issues, but it would be extremely helpful. Interoperable, we talked about it, SNOMED, LOINC, we should apply that, and also think about clinical concept, and the data should be reusable. So they should be published ideally under license, which allows also other researchers to do that, to use the data. And then also one funny thing, what happened while we trained our algorithm, we found patients which were kind of healthy. They were on an ICU, but they were kind of healthy. And for some reason, organ failure or even death was predicted. We're like, how could that be? It doesn't really make that much sense. So then we really went into those data, and what we figured out, all our data are coming with a timestamp and with a date. And usually we do lab work at around 7 in the morning. And if a patient has a severe issue, for example, at night, 3 in the morning, we also do lab work because we need to figure out immediately what is going on with the patient. And then we figured out that patients who are very healthy, but for some reason got admitted at 3 in the morning, because at every admission we do immediately a lab work, they also got predicted at having some severe issues. So then we figured out that the algorithm also, as a confounder, learned lab work at 3 a.m. in the morning is a very bad, or is really pointing to something that there's probably an issue. So that was a confounder, so we removed that. And this is just a very small thing, but it should show and demonstrate you that you as a researcher, or when you're applying AI models, you really need to understand if the model is something not predicting correctly, and even if the accuracy kind of high, you always should understand why is something not predicted correctly. And then you really need to go back into the data and try to find patterns or mechanism which could lead you into the direction what is going on there, because it's very important. And then also we are using again explainable methods here on our ICU data, where we also really try to understand what is really important. in predicting organ failure or sepsis. And I also said at the beginning, regular auditing and monitoring is important. And I want to remind again that static and that we have static and adaptive machine learning. And when you look here at the end of the slide, the FDA did know something which is really smart. So they have predetermined change control plans for AI models. It was published already in 2021. And what that means is, so when you apply for certification of your software, which also uses AI, you implement a change control plan. That means you say, okay, after this and that time, I will update my algorithm, and I will measure bias and performance of the algorithm in this or that specific way. And then you don't need recertification. And this makes a lot of sense because of all things which we just heard. And currently we don't have that in Germany yet. I hope we will get that because it would extremely help in implementing more and more AI models into the daily clinical work. Yeah, and then I said it at the beginning, when we look more in the future, the big question is still what level of bias is acceptable for an AI algorithm. And then the next question is also what kind of accuracy is acceptable. And there is no answer yet. There is discussion about it. Of course, you can't really expect any performance discrepancy just in clinical studies. In real world, you will have that. But the question is it really that bad? When we're also thinking about precision medicine, and that cases are very different, we will have discrepancies. And I think it really depends on the task of the AI algorithm. So we really have to think from case to case. But it's really an ongoing discussion. And of course, AI models must be more and more explainable. We know that also in particular in Europe because of the European AI Act. But there will also be a debate and a discussion about how can we even measure it, what is really the right explainable method, because also those explainable methods, because they are methods, they also have issues. And so it will get really interesting. How will we assess performance, and in particular when we come more and more to the continuous learning AI models. And yeah, the take-home message is, when we don't use AI, is it malpractice? So where should we really implement that? Do I need AI, or is probably logistic regression the best way? Just using AI, I think, doesn't make sense at all. So the question is, do we really need it? And where is AI really supporting us? Does it really help us? Then plan your study. The thing is really important that you also think about who is using it, are the data the right, is the model the right, and integrate bias detection and mitigation plans. Thank you very much, and I'm happy to take your questions.
Thank you very much for your talk. So again, we will start in the room. Questions? Yes.
Hey, thank you for your talk. It's really interesting. For the dermatological AI that you had, where it had to identify skin lesions, what was the gold standard of the original diagnosis that you used there? Was it dermatologist diagnosis to identify whether it did it correctly? Or did you have another method for ensuring the accuracy? Sorry, I've got really dry throat.
Yes, so basically the labeling of the data was mostly performed by dermatologists. So when we used those publicly available data sets, they were labeled by dermatologists. And for the mpox data, it was a little bit different. Some data sets which we used were labeled by dermatologists, but some also by infectious disease experts.
Okay. there are questions in the chat?
Everything is clear.
Maybe.
There's a question.
Yeah.
Yes, so looking at your great talk, by the way, very nice. Looking at your Mpox work, when I look at it as a sort of a virologist, I'm like, where's the training set for chickenpox data lesions? Because that's apparently one of the most difficult one to disentangle. So that you consider, that's of course, yeah, I mean, going by literature, you could go the way you go, but you could also say, okay, what is in the differential and do I need images for that one?
So chickenpox was included in those publicly available data sets. So there were also chickenpox images in it, not that many, unfortunately, but they were also in it there, yeah. So yeah, sometimes it's also a question, even when you look into publications and you try to get images of there, that very often you have like only one or two, and sometimes it's even from the same patient. So, but of course we tried to get it because we also did the scientific literature and we tried to get as much as possible. Yeah.
Okay. Yeah, in the back. Could you? Yeah.
This is probably going to sound like a really ignorant question, but is AI being used to diagnose in Germany at all, like for real? And is there a legal sort of framework that controls it? And you don't have to expand very much, just like it's a...
Yeah, it is. So it depends in different kind of settings. So for example, for DIGAs, some DIGAs using AI. I don't know if you're aware of DIGAs that are digital health application. So what you do is the first is you need a CE certification. Then you need to get licensed now under MDR. So medical device regulative depends on, so usually when you have AI, it's at least 2A. And then you need to get a certification of BfArM. So you have also application process, but it's in use, yeah. And for radiology, there are also a few which are in use. But unfortunately, we don't have a list. For DIGAs, we have the BfArM list, which is publishing all the accepted DIGAs. But for other software which is using AI, it's unfortunately there's no list. So there are not real numbers about how much is, but it's used. Very often it's also as a built-in software. So for example, you buy an ultrasound device, and then there is also support of AI, which is licensed then, but it's locked, so it cannot earn more. Yeah.
So there's a question from...
Yeah, there was a, sorry, just the, so is there a legal framework for AI diagnoses? I mean, is it legally regulated, let's say?
Yeah, it's regulated, for example, under the AI Act. And when you use AI, usually, so it's, for example, if you use AI within an app, you know, it's a medical device. And then the question is what it's really doing. And then MDR applies, medical device regulative. And so then you have to apply for that. But how the specific process is and how does it work, there I'm out. So there we have to ask legal experts. But there is a way, yeah.
Okay. So then we...
Sorry, I have one follow-up question on the chickenpox one. First of all, I'm in awe of clinicians doing science as well. It's really impressive, very nice work. So the accuracy that you showed us for that model, that was about everything, right? About classifying all the different lesions, the chickenpox, the Mpox, or did that somehow just refer to the Mpox classification?
I'm not 100% sure if I understood it. So what we did,
so basically, did you also correctly classify everything else other than Mpox?
Yes, yeah, exactly, yeah.
Thank you.
Yeah.
Yeah.
Yes, thank you. Thank you very much. Very interesting talk. Fascinating. Now you mentioned that postcode and the time of diagnosis might or might not be a true confounder, and then you remove them. And now my question, I'm sure that you didn't do that like Musk did it with South Africa and Koch when he recently changed the patterns of answers. But having read Silverstein in 10 years ago, where he showed that one of the potential confounders is the statisticians and the experts who built the models. Do you have any objective criteria, or do you think there are objective criteria when to play with a model and how, not to introduce more bias or unknown bias or different bias by trying to reduce bias?
Yeah, that's a very important question. It's not really answered yet. So what we're doing, in some models, we still have it in, it's current, it's ongoing work. So for my opinion, it should be inside, because the goal is not to remove something, because each data point gives you more information. So that's not really the point to kind of remove it. And what we do is that we, of course, write exactly down what we are doing, so you also have, of course, timestamps, so you know which model is trained with what. So this is, of course, there. And then the question is, when you do data pre-processing, like with labeling, of course, it can always be that you introduce more bias. And it's very often likely that as a human being that you introduce your own bias when you do something, because you think about something, you have an explanation, you do something, and probably that is very biased, even more than the raw data. So the question is, do we really need to do something? And I'm currently going more into the direction I would leave the data as they are and not really doing something, because it also shows that the algorithm isn't working that well when they focus on things where they shouldn't focus on. That means that the learning itself, the pattern learning, is not as good as it should be. Yeah, but of course, I mean, there are already studies, as you know, as I said before, AI plus human beings. Everybody thought this is perfect. It's completely wrong. So even in my bias mitigation, probably this is a hint, but I don't have data about that. So, and it's hard to test. Yeah.
So one last question from the room, and then one very last question from the chat. So.
Hi, yes, thank you for your talk. Very fascinating. Also the question you raised, I mean, this is a really big one, is will it become malpractice if you don't use AI? And then if we extend this to also the research community, will it be bad scientific practice if we don't use AI? But then also if you use it in the wrong way, just as touched in the question before, then it's also bad practice. So we need to be very, very careful in using this to make better research and better science. But the ramifications of that require a lot of society or discussions within the research community and also the medical community. Are there already discussions going on how to integrate this into medical practice and then also research?
Yeah, so I think in general that are very huge questions. So I mean, some things are, for example, the EU AI Act, which is like really defining when can AI used. So this, this sets standards. Then it's also that for high risk AI usage, for example, like in medical area, it must be explainable, but it's not really defined what that means. And even those methods, can be also lead to problems in interpretability. And then, like I showed, the FAIR standards, this is also an initiative, is how you should publish your data sets and so that everybody can work with it. So the answer probably is that, in my opinion, the scientific community is really working on it to make AI models more comparable, to make data sets more usable and comparable, which is basically the first step. But of course, there's a lot going on, and there's also, which is called the praise, that was published in JAMA. This is a recommendation how you should publish an AI model. So what should you even show? So for example, how it was trained, what kind of hyperparameter tuning did you do? where it's also asked that you publish different kind of results and different kind of subgroups. So I think there are so many different areas which needs to be standardized more, and there's a lot of work going on, but I think we are just at the beginning.
Okay, so now the online question.
So just one question in the chat. Can you explain again why the Mpox AI wasn't asked to make a binary decision? What was the problem there?
That we had a very imbalanced data set. So we had more than 150,000 images non-Mpox and about 700 Mpox. So the algorithm would be forced to, when they always say it's non-Mpox, it would have a very high accuracy. So when you have very imbalanced data sets, a binary decision is not working well.
Okay, thank you very much. Again. So, we will start the second part of the day, 20 minutes after 3, and there's coffee and I guess some snacks at the entrance, so feel free to join.
Okay, welcome back from the break to all of us in the room, and to the people online. We're now going to continue with the next 2 talks of the day. Every year at the Robert Koch Colloquium, there is one internal talk by one of the colleagues of AKI. And this year, the honor goes to our esteemed colleague, Professor Julika Lars. Professor Lars has worked in the field of public health for many years, with a focus on health-related behaviors such as physical activity, dietary habits, and smoking. She is the head of the unit called Health Behavior at the AKI, which, as the name already suggests, is responsible for the national monitoring of health-related behaviors. Julika has authored articles and book chapters on e-health and the link between health behavior, and social networks. Over the last years, she and her team have explored how wearables, such as smartphones, smartwatches, could be used for collecting data on the physical activity of the population. We look forward to her talk, which will address how to use sensor-based data from wearable devices in health monitoring. Welcome, Julika. The floor is yours.
Yeah, thank you very much. So my topic today is how can we leverage the potential of smartwatch data or of fitness bracelet data for population-wide health monitoring, given that so many health information, large-scale health information, is out there generated by these devices worldwide every minute. And I will start first with giving you a short definition of what I understand as health monitoring in the context of this talk. And I would basically use it interchangeably here for the context of this presentation with public health surveillance, meaning the ongoing systematic collection, analysis and interpretation of population-wide data with the aim of quickly disseminating the results of these data back to those who are making decisions on prevention or healthcare. I will not use the term health monitoring in the context of clinical data, because a lot of wearable studies are taking place in the clinical setting, but I'm with patients, but I'm not referring to that. I'm only referring to population-wide data today. Most countries have indeed implemented a routine public health monitoring system, and they collect data on chronic diseases such as diabetes or cancer or hypertension. They collect data on symptoms such as pain or depressive symptoms, and also on certain health-related behaviors such as smoking or physical activity. At RKI, we are performing the health monitoring for Germany, so the national health monitoring. And our interest is also to feedback the information rather quickly to decision makers and to health practitioners. And we do that with a web platform, with a dashboard, which here is an example of depressive symptoms, shows you, for example, the prevalences according to region, according to gender, according to education, and also gives you time trends of prevalences. Here's another example on physical activity, who's meeting the WHO recommendation for physical activity. And also here we look at prevalences according to region, gender, etc. In order to get an understanding of these behaviors or symptoms, health monitoring usually relies on regularly written or phone surveys or on examination surveys, also supplemented with health claims data or clinical data or official statistics. But health monitoring has not yet really made use of the advances in sensor-based devices. Practically nothing has been done in that area, at least in Germany. But it might be worth trying or giving it a try because, as Stephen Gilbert puts it so nicely, the center of gravity of health data is shifting away from the hospital to the sofa, to the wrist, to the pocket. And this is what we want to tap on when we start thinking about how we can use wearable data. What capacities do wearables have, and can we use them for health monitoring? So you all know that in the recent years, the availability of technologies, of consumer technologies, has increased dramatically. And there are smartwatches, there are patches, there are garments, there are small portable devices, there are all kinds of sensors, and they can measure a lot of physical performance variables, for example, cardiorespiratory function or emotional state or sleep, whatever. In this talk, I will focus on smartwatches and fitness bracelets, because these are the devices most widely used, and therefore they're best suited if we think about using wearable data for population-based monitoring. And in fact, smartwatches have now really transformed into devices that can collect lots of health-related data. For example, step counts, activity level, blood pressure, sleep duration, sleep quality, etc. The technical state of development between these measurements is rather heterogeneous. So we have rather accurate and consistent findings, for example, for step counts, but the validity and reliability is more varying in terms of other parameters, for example, blood pressure or arrhythmias, but the sensors and the algorithms are getting better and better by every year here. And there's already a couple of studies that have made use of these smartwatches. For example, like 5 years ago, Apple has started enrollment in 3 huge health studies, which were designed together with academic partners. For example, I won't go into detail. This is just to give you an idea what's happening out there. For example, the Apple Hearing Study, which is making use of the decibel measurements of the smartwatch, or the Apple Heart and Movement Study, which correlates activity parameters with risk for heart disease. And these studies are aiming at collecting 500,000 to up to 1 million participants in order to better predict certain outcomes. And of course, this is fair enough, because the distribution of smartwatches is increasing every year. Because of, the smartwatches are getting cheaper and they're getting nicer, and they have more and more facilities and capabilities. Can I ask you, who of you owns a fitness bracelet or a smartwatch? Can you just raise a hand? Okay, yeah, that's not too bad. We wanted to know the number of people in Germany who, of a representative sample, who own such a device. So we included questions on that in a representative survey we've done at the RKI. And we found that 90% of the population own a wearable, but that was back in 2021, 2022, so that might have even increased since then. We were also interested whether these people were willing to donate their data to us, to RKI, to make research for that. But that was a bit sobering because, well, it was not more than 50% who maybe would donate their data to us. And we found similar results in a comparable study done in the US a bit earlier, where 22% of adults said they owned a wearable, and 40% of those were willing to donate these data to public health agencies. So this also goes back to the issue of public trust that we discussed earlier today. So this obviously highlights a challenge for using wearable data for population-based monitoring. So we have to do something about that. What are potential? Why are we talking about wearables at all? So it's three characteristics of big data and also wearable data that make it attractive. It's volume, variety, and velocity. Meaning, for example, the data we get are much more comprehensive. For example, in terms of physical activity measurement, when we take a questionnaire, we can get a rough average estimate from the participant about the last week's physical activity behavior. With a wearable, we get very accurate, precise information, maybe not only for a day, but for weeks and months. The data are coming in really fast. And what is also very important is these are objective data, because when we work with questionnaires, there's always something like a recall bias, like a social desirability bias, and we can exclude that. This is why it is attractive, but this also comes with strings attached, obviously. And there are four main challenges that are always mentioned when people discuss challenges connected to wearable use. The main aspect being representativeness. And we've talked about bias in the former talk, and selection bias is also something which is really important because people are purchasing a wearable for a reason, because they are health conscious, or they are sporty, or they are tech savvy. So probably the sample of wearable owners is not very representative of the population of interest. So we have to keep that in mind. And you can see that very nicely in this forest plot. This is from the survey we did in 2021, 2022 about the wearable owners. And we did some odds ratios for those who collect health data with their own wearable device. And we found significant that, for example, I'm supposed to use this one. High income, for example, or PA is physical activity. High level of physical activity are significant predictors of owning a wearable and collecting data, whereas, for example, the older parts of the population are underrepresented. So this is what you almost find in every study who is looking into that. Then, of course, missing data is a challenge as well, because people may not wear the device all the time. And typically, they're wear when they are most active. So if you want to impute missing values, you have to keep that in mind, that the missing periods are not representative or cannot be simply imputed from other ones. And I've mentioned earlier, there are concerns about validity and reliability. And there are good accuracy values for example, step counts. Activity levels is a bit more difficult. And whenever you've finished some validation study, you validated a certain variable against a research device, then a new software comes up and a new hardware upgrade comes up, so it's all outdated very quickly. So you have to keep up with a continuous updates and upgrades of the companies, which very often they won't even tell you that they've done that. And basically, what is a big problem as well is that the proprietary algorithms, which convert the raw data into the parameters that you can read on your device screen, is undisclosed. You never know what the company is doing to calculate these variables, these metrics. And then, of course, they vary between different variables. So there are for the time being, like hundreds of thousands of different wearable devices out there. So when you tap on the devices, user-owned devices, you have a huge variety of data coming in. So you have to sort of harmonize this, basing on comparison studies, etc. So that's a big statistical challenge as well. So it is important to use this big data with clever, smart statistical and design methods in order to come from big to smart data that we can use for reliable population-based health monitoring. And of course, the last and really important challenge is about privacy issues, is about data protection. So we need to make sure that participants cannot be re-identified through ensuring security of storage systems or of the devices. And it's also, and that's the experience we also already had, it's really quite complicated to explain these privacy issues to participants and also to institutional review boards, because the technology is quite complex and difficult, and it's not an easy to explain topic. Keeping all these positive but also drawbacks in mind, we will look into a use case of physical activity measurement, because this is the area where my team and I have been working on a little bit. It's about physical activity and also sleep. And it's an important public health issue. Most of you will know that, because physical inactivity poses severe health risks, for example, cardiovascular risks, cancer risks, mental health problems, or even has a negative impact on the course of infections. And over the last years, evidence is increasing on the health risks of short sleep durations, which are connected to obesity, to hypertension, coronary heart disease, and even to a higher mortality. So it's also interesting to look into that more, because we know that due to using all kind of mobile media device, sleep duration is getting shorter and shorter over the last years. So, of course, when we want to monitor physical activity and sleep, it's important to see time trends and also to see differences between socioeconomic groups. And we usually do that, I mentioned that before, with questionnaires, with the disadvantages like social desirability, recall bias. And also sometimes it's quite difficult to explain to the respondents, okay, is it a light or moderate or vigorous physical activity? So everybody maybe has a different idea of what a vigorous physical activity may be. And this is where activity sensors come into the picture. Activity sensors consist of accelerometers, which measure the acceleration in 3 different axes, and they have usually or traditionally been constructed for airplanes and for airbags, but they've become smaller and smaller, so they can now be built in every smartphone and in every wearable, even in the wearable rings. So they're really, really tiny now. And they deliver data that can be calculated to know something about step counts, about light, moderate, or vigorous physical activity, and also to learn about sleep duration and sleep quality. And sometimes this is combined with heart rate information. And there are a couple of studies that have already made use of accelerometers. For example, the study that has been done here at RKI, the Corona Data Donation Project. This project, some of you may know that, has been launched during the pandemic, and 500,000 people installed a special app with which they could donate their data, especially data on heart rate, step count, and sleep, to Robert Koch Institut, and the study was headed by Dirk Brockmann, formerly RKI. He was now a professor at the University of Dresden. So these data were collected with the aim of calculating fever spots, but you can look up the sleep or physical activity results also on the website of the Corona Data Donation Project. For example, here you see regional differences in sleep duration between 2020 and 2021. So you see there are regional differences, but there are also differences in time between the years. Or for example, they have also calculated sleep duration according to gender and to age. So you see that women are sleeping longer than men, for example, and the younger ones sleep longer than the older ones. So these data can be really calculated nicely using wearable devices. One of the first studies to use accelerometer sensors was a study called Activity Inequality Project. And they used data from more than 700,000 individuals. At that time, they didn't use wearables, but smartphones. So the accelerometers, the sensors are built in the smartphones in more than 100 countries in order to find out more about inequalities or disparities in activity. And there are lots of interesting figures and curves and stories in that paper. I won't go into detail here, but just one thing that I find really nice is that they mapped activity or activity inequality with the walkability of certain cities. So you see that the more walkable a city is, the smaller the activity inequality is. So there's really interesting data that can be generated out of wearable sensors. And the third example I want to show you is a big study. Some of you might know that the All of Us research program from the National Institutes of Health in the United States, where the participants are invited, if they own a Fitbit device, to donate their data to that research program. And a couple of researchers at Duke University has analyzed data from 70,000 participants, then has looked into the step counts in different US states compared to the average temperature in these states, and has come up with this picture showing that the warmer the average or the warmer a state is, the less the people are walking in these states, which gives you an idea maybe of what might change if global warming is proceeding also here in our country. So to sum up these studies, there is merit in using wearable data in activity measurement for seeing time trends, changes over time, and also maybe seeing effects of certain events. Maybe there's a heat wave, do people tend to walk less? You can see regional differences and also make out effects of certain environmental factors, and you can see differences between socioeconomic groups. It has been difficult for the obvious reasons to find, representative prevalences for physical activity behavior. And we were interested whether we could change that by not using data from user-owned devices, but by going the other way around, sending out commercial wearables to a sample of a representative population-based sample. And we wanted to do that in a feasibility study, which I will present you, which is quite recent. It was called Exercise and Sleep. And this study was basing on a quite novel cohort of about 45,000 participants, the RKI panel Health in Germany. And these participants have consented to be surveyed on health issues repeatedly. And we were interested in knowing whether it's practical for the panel participants to get a fitness tracker and use it in their daily life, and whether the collected data are useful for us in terms of using them for monitoring sleep and activity. Especially, we wanted to understand more about the technical procedure and about whether there was a sampling bias, because we wanted to eradicate bias by sending out the fitness bracelets, but we're not really sure whether this would work out. We bought 150 devices from a French company called Withings, and they are quite often used also in clinical studies. For example, Charité is using it in a couple of studies. And the positive aspect is that it's based in Europe, so it's easier in terms of data protection. And the bracelet was worn for 2 weeks last December. Here you see the procedure of sending out the bracelets. The first step was recruiting. So we kept 3 because they were not working properly because we've tested them before. So we sent out 147 bracelets by recruiting people with information materials. Then they were mailed, the bracelet and information materials at home. They needed to register in the tracking app. So this is the company's app, like the Withings app. You know that you can only make use of a wearable if you download the specific app. And they had to download an additional app, the study app, which provided the data to us. This is always every data donation project only works with an additional app. Then they wore the tracker for 2 weeks. Then they were asked to participate in a follow-up survey, and then they were asked to send back the trackers. So go back one step. This was the trickiest part because our data protectors said, well, you're not allowed to, or the participants are not allowed to give their proper name because it would make them re-identifiable to the company. So they had to use an alias. So we produced pseudonyms that we sent out to them. They were quite complicated. And then we had QR codes for the study app that were matched to the pseudonyms. And this was all done in order to circumvent the data protection concerns, but make the whole registration act quite complicated. And you could see that in the participants' numbers. So when we ask like 700 panelists, would you be willing or interested to join the study? We had an immediate response of 1/3 of the invited people said, yes, we would be more than willing to take part in that study. So that was really easy. But then only 80 of those actually downloaded both apps after they received the trackers, and only 70 provided data. And it was then only 64 who also finished the follow-up surveys. So the main dropout was around this aspect. And we were also interested whether the sample composition changed through this dropout period. So what we did was that we compared the samples. And here you see the blue columns is the composition of the sample which consented to receive a wearable. Yes, we would like to receive a wearable. We want to participate in the study. And the green columns is the people who eventually provided the data to us. And you see that during the registration, so in the beginning, the blue columns, the sample was quite evenly distributed in terms of age groups, but the sample was skewed towards younger age when it came to actually providing us with data. So we wanted to avoid sampling bias, but then we sort of undermined that procedure by the complicated process of registration, and we had ended up with a certain selection bias. So in summary, so we are still working on the results here, but the first preliminary findings, it was quite feasible. People were really keen to participate. We had a good sample at the beginning, so we had no real biases in the beginning. It was easy to use the data, but the downside was the complications at registration and the high dropout rate. So we will build on these lessons to try to develop that aspect a bit further. So there are pros and cons to both kinds of data collection. I think I've elaborated on most of that. So you can use the data from user-owned devices. You can send out wearables to the population, and you have to decide which way is better for which research question. So in summary, I think wearable data can have their merits in population health monitoring. The strengths lie in the detection of regional and social disparities and in time trends. But public health needs to, what I call here, set the scene for harnessing the potential benefits, and I think we are not nearly there. There is first the thing that the sensors and the algorithms are developing at a speed that it's really, really hard to keep track. We have to identify what are the best research questions, where can we harness the best benefits for health monitoring. So maybe we do not really need 1 million wearable user data in order to see, okay, older people are moving less than younger people. So we really have to have good research questions, similar to the former speaker who says, okay, when do I really need AI and when don't I need AI? So this is quite similar to that. And then we have to think about good study designs, of course. We need to have the adequate systems for obtaining, storing, and analyzing the data, and these systems must be secure and they must be scalable. And I think what is really, really important is that data scientists and public health scientists need to work closely together, because this is a big challenge, you know, making sense of the big data. So we need good strategies in design, in statistics to overcome the methodological barriers here. I think triangulation of variable data and representative survey data is the future. So we need to find ways to make sense of both. And I think it's really important to get a common understanding of privacy issues, data protection issues. This is where public trust, again, comes into play. And trust, of course, in institutional review boards who understand what we are trying to do here. Thank you very much for your attention.
Thank you, Julika. Thank you very much for the great talk. Now we have some time for questions.
Thank you. That was fascinating. The companies that manufacture these devices, don't they have all the data, and can't we get it from them?
Yes, so that is a pretty good question. So basically, now most of the companies, they do have like privacy conditions that exclude the use of wearable data for research purposes. So, for example, Apple etc. does now not allow use of research, but like the oldest studies, like that huge study with the 700 smartphone users worldwide, I read it up and down and tried to understand it, but I think there was no informed consent given by the participants. They were not knowing that their data were used. But I think that awareness has changed now. So I think it's getting more and more difficult. The solution would actually be to include some kind of, you know, a question. Would you be willing to donate your data on a platform, like a platform that researchers from our country can access? I think this would be something for the future. Or you have to cooperate with the manufacturers as a researcher, which is pretty tough. I mean, we tried to contact this Withings company and, you know, 150 wearables. That was not of real interest to them. So it was really hard to communicate with them and get them for a cooperation. So you really have to, I think, have a lot of money and a lot of, you know, large scale data. Then companies might be interested.
For online participants, you are also welcome to type in questions. So one question from the WebEx.
Yeah, it also fits to the previous questions. So why did you choose the French company? So why wasn't there a German brand you could use? And or other like Swiss, the Garmin company. So what was the reason for the French?
Yeah, so the reason was that you have to make sure that the data are stored within the European Union. And most fitness trackers do not store the data in the European Union, but on some, you know, Google servers or whatever. So they are stored in the United States. And this really makes it difficult for you to make these studies. There's no German producer, at least. And then the other thing is you you need devices with a sort of high validity of metrics. And then you need rather cheap wearables in order to make it affordable for you to send them out. And the Withings is a good compromise because it was like 100 euro per device, and it has been tested in quite a lot of clinical studies. But then when we read through the like 27 pages of all the small size text, it turned out that while the server was in France, they sometimes do some backups on a Google server, which made the whole thing very complicated. Yeah, so it's really difficult to find an only German-based or EU-based company that you can work with.
Dennis?
Thank you, really lovely talk. I also wondered about incentive because at the beginning you were showing that people weren't so interested in sharing their data, and the first speaker today also alluded to that. So I guess in the study you showed, the incentive was that people got like the device for free for a couple of weeks, but then if you wanted people to use their own, it would make sense to try to make the data accessible also to their doctors, right? So the idea of a platform that you just mentioned, I think is a great idea. Is there any chance, I know we're in Germany, it's super difficult, but is there any chance that this could then be linked back to the health system so the people can actually also make use of it in some way?
Yeah, so especially if you consider our first talk today, that would be a brilliant idea. And I think this would also sort of leverage the willingness of people to donate their data, because it's quite interesting. I mentioned that there's about 40% of people who said, well, okay, I would donate my data or share my data with the public health institutions. There are studies who have tried to see whether there are differences between the recipients of data, and they saw that almost everybody would be willing to share their data with a health practitioner, so with their personal doctor, and a little less were happy to share the data with a manufacturer, and then very low-ranking government and public health agencies. If your health professional, so your GP, etc., comes into play, probably that would motivate people even more to share their data. So that's a good idea. We haven't thought that through actually, but that would be a good idea to pursue on that. Yeah.
But does the health practitioner know what to do with that data?
Well, of course you would. Yeah, you would need some good service agency to transform the data from the wearables to something that is really usable in daily life. So this is what we actually did. So the raw data or the data coming from the devices went to another agency, and they sort of calculated the metrics for us. So how many minutes of light, moderate, vigorous physical activity. So we had another sort of agency because we are not able to work with like big data, but there are companies that can, and then sort of can make it usable also to health professionals. But you need this kind of a broker to make the data usable for health professionals. Yeah, it's a really important point.
Thank you. There is one question over there, and there is one online.
Thank you. Yeah, thank you very much for your presentation. You mentioned the use of these software for sleep and for sport, and I'm wondering, would there be a potential also to track your live location, or is this maybe too sensitive of information to be shared? Because I'm thinking particularly of studies that look more about environmental exposures, and in that case, maybe also looking at the movement of the people could actually be very helpful.
So did you say vacation, or did I?
No, live location.
Live location.
Location of people.
Yeah, of course. You can connect that. That's quite easy. So you can connect that to geographical data. This could be done quite easily. And of course, I mean, there are all kinds of things. You can even use microphones and then see, okay, somebody on her own, on his own, or is he or she in company? And does that make an impact on physical activity behavior? So you can feed in all kinds of information, but of course you need informed consent of the participants to do so. And I think the more information they need to feed you in, the smaller the willingness will be. But of course, this would be possible, yes.
Are there more studies with wearables planned at the RKA? And how would you address the past issues with the data security in those new studies?
Yes, yeah, we are of course after that feasibility study, we are now thinking about what to learn from that. So we are having a couple of ideas. So, for example, we try to make the procedure more easier, find ways to make it acceptable in terms of data protection, but also easier for participants. Then the other idea is to tap on user-owned devices by sort of recruiting a representative sample within our panel who own a wearable. So there are a couple of ideas how we can make use of these wearables.
Further questions? Okay.
Yeah,
Thank you very much.
Thank you.
Okay.
Yes.
Okay, let's continue. Our last speaker of the day is Professor Sebastian Funk, who is a professor of infectious disease dynamics at the London School of Hygiene and Tropical Medicine. There is also abbreviation for that, SHTM. Maybe you all know it. So Sebastian and his team develop and apply computational model in order to better understand and ultimately to predict the spread of infectious disease. This can include modeling of the dynamic of COVID-19, but also other emerging infectious diseases like Ebola or Mpox. The aim is to inform decision-making in real time. Similar to our collective experience in weather forecasting, models can sometimes also get wrong. And much of the work at Sebastian is also looking to how to evaluate models and improve their performance. So he has worked with many other colleagues internationally, including also projects together with RKI, ECDC, and the WHO Hub for Pandemic and Epidemic Intelligence. We look forward to his talk, which will address how to model the infectious disease dynamic of the emerging threats. Thank you, Sebastian, for coming, and the floor is yours.
Thank you very much. That sounds great. So given that this is a symposium about data, you might think it's slightly odd to have a talk about modeling in here, which is sometimes seen as a somewhat data-free zone. That can be the case, but in reality, I would argue that if you analyze any kind of data, if you perform any data analysis, you will always use a model. And one way to think about this is that models are a way to combine things that we know, so what you might call the data, with some assumptions and theory, which is what we think, to learn about things that we don't know. So this is how we make estimates, or we want to find out things. And even if you use something as simple as a linear regression model to analyze some data, you are making assumptions, maybe implicitly, maybe explicitly, about your data and how different parts of your data, or maybe your predictors and your covariates, are related to each other. And that is ultimately what you do anytime you analyze a data, so you are using a model. And to give you a bit of a motivating example of the kind of work that we do in the context of infectious diseases, I'm asking you to travel back in, I know it seems a long time ago, but to travel back in time into January 2020, when we were doing work on a very specific question about COVID-19, and that is whether it could be controlled by contact tracing and contact tracing alone. So we started this work in early January, when all the data that was available about COVID-19 was from Wuhan in China. So there were no international cases at that time. And in collaboration with public health colleagues and with the UK Health Security Agency, we're thinking about this question of contact tracing. So If you think about how you might want to address a question like this, like can this disease, and we have some emerging information about this from somewhere, can it be controlled by contact tracing? And you might think about this, and you might maybe use your experience or intuition or something like this. But these are generally not always great guides, and it might be quite fuzzy, but you might want to think about this in a slightly more structured manner and think about, okay, so what do we know? So we know kind of it's maybe how transmissible it is. You might see what the increase in cases is from the data that you get. You might think about something like, what is the incubation period of this? There's some reports of asymptomatic spread, and you might want to start putting these together and build some kind of sense of what might play out. And what a model in the way that we use it does is simply to formalize this notion and to translate this kind of, and in fact, the hardest job generally in what we do is to translate this sort of mental model that we might have into something that is written down, be it in equations or in computer code or something else. And what we did looks something like this. So it's a pictorial representation of something that we did in computer code using some previous modeling code that we had from analyzing ring vaccination for Ebola in West Africa. So something that might be quite different, but has certain similarities, especially the sort of going from person to contact and then performing some sort of ultimately a public health intervention or something with the person that is being traced. And can you see this? Yes. So you might think about this. So you might have an initial person. So that person is not part of the contact tracing system, becomes infected. There's some incubation period. That person, let's call them A, develops symptoms. And then there's some kind of delay from entering the system or being visited by contact tracers or whatever is necessary to establish that that person is indeed likely or at higher risk of being infected with this disease that is being traced, in this case, COVID-19. And then after that delay, that person is being asked to avoid all contacts or is isolated. And then any subsequent infection that could have happened no longer happens because that contact doesn't occur. However, depending on what the length of the serial interval is, in the meantime, that person may have infected two others, person B and person C, who, with their own incubation periods, develop symptoms, but because the individual A has been isolated, person B might, at the point of developing symptoms, then be isolated at the same time as person A, once it's ascertained that that person does indeed have COVID-19 or likely COVID-19, and again, subsequent infections don't happen. This is a person that's been traced, so there's maybe a probability there of becoming traced. And then, however, person C, who does not get traced, goes through the full incubation period and their serial intervals and infects others. Okay, and this is here a pictorial representation of that. Now, in writing this down and developing this model as a computer simulation, what you can do then is, under certain parameter regimes, such as the one that we had some information on, as well as some others that we didn't, you can explore different scenarios, or you can start analyzing how this would play out and whether you get an uncontrolled outbreak or whether you're able to control using this contact tracing as implemented here. And these were some of the results. As stated here, it doesn't come particularly surprising. Perhaps probability of control depends on intensity of transmission and contact tracing efforts. But we use this to explore, for example, with different possible reproduction numbers. It wasn't quite clear at the time what it was. In reality, it's probably somewhere between 2.5 and 4, but different scenarios. And depending on the proportion of contacts that were traced, we could look at the proportion of simulated outbreaks that became controlled. And correspondingly to that, see how the reproduction number, the effective reproduction number, or how many subsequent people were infected by each infected person, how that developed, again, as a function of the number of contacts traced. And I mean, by now, so now we know that we weren't in that red scenario, but it's more between those two or those two. And what was fairly obvious from this is that the window of ability to stop outbreaks by contact tracing alone was pretty narrow. So you need pretty perfect contact tracing, as well as be fairly in a fairly benign regime as far as the reproduction number and the other things that are not shown here, like proportion asymptomatic and so on, were concerned. Now, in some sense, that maybe illustrates that a model can be quite powerful in sort of allowing people to think through a reasoning and follow assumptions through to logical consequences, but it's also not perfect. And in fact, the fact that it wasn't perfect was pointed out to us in several comments to our study that were subsequently published. And just as one example, this one, which argued that the potential impact that flawed model inferences can have on public health policy, and the fact that our study was linked with the fact that the UK gave up contact tracing fairly early on in the pandemic. And our study definitely was wrong in some ways with hindsight, with aspects that we didn't know then. And I should say that our study was first published on the 10th of February, 2020. So that was at the time when there were 8 cases had been detected of COVID-19 in the UK. So it was very early on. It was rapidly done work, and some things simply weren't known by then. But one thing that we hadn't considered is the fact that individuals might be tested before they develop symptoms. So we had this trigger for isolation upon developing symptoms. But of course, if you test people before, then you might isolate people more rapidly if you don't wait for a symptom onset, and you might be more effective in your contact tracing. On the flip side, we were certainly very optimistic as far as the number of introductions were concerned, because our baseline scenario had 40 introductions. And as we found out later from genomic studies, there were more than 1,000 separate introductions of COVID-19 into the UK. All of this to say, really, and we often quote this, this is a very popular quote amongst modelers, which is that all models are wrong, but some are useful. And what might seem like quite a clever statement and something that we like to cite, in reality, I think it poses more questions than it answers, really, because you might ask, well, how wrong are the models, and in which way are they wrong? And does being wrong matter for being useful? And if only some models are useful, how do we know which ones are useful? And these are, I will talk about these aspects, mostly about models being wrong or right, in the sort of next middle part of my talk, and a little bit also about what we're trying to do on understanding when and how models are useful. Okay, so first of all, let's talk about how wrong are models. And this is generally quite a difficult question to answer. So because there's this kind of slightly woolly concept of having assumptions in there, and the assumptions might be wrong, but in which way is maybe not always clear. But there are some ways in which we can actually look at models being right or wrong, and that is with respect to specific predictions that they make. And in order to get a bit closer to that question, I invite you to look at this time series of case incidents. And I realized, talking to a room of public health practitioners, this might be slightly triggering to just see cases and time here. But for the moment, just pretend that you don't know what exactly this is. And I'll show you in a moment. You don't know what this is. You are at this moment in time here indicated by the dashed line. And I'm asking you what will happen next. Okay, so you might, again, develop a little bit of a mental model here. So you look at this time series. So maybe there's a bit of a general trend of increase here, but then there's also these sudden drops. So they might seem to have, is this the beginning of another sudden drop perhaps? So you might, one way or the other, imagine for yourself, you put another data point there. Yeah, this is your predicted data point, what will happen at the next time. And ideally, you don't just make a prediction, you also give some uncertainty around that. Okay, so maybe also based on everything that you see here, you might want to associate some uncertainty. Now, I've promised I will reveal to you what this is. So this is data from Germany, actually. So this is the consultation rate with acute respiratory infections per 100,000. I think, and I realize some people in this room might know this better than me, I think this is estimated from Sentinel general practitioner practices. And then you also have a date here. And those who are familiar with looking at these kind of time series, you immediately see that this drop here is almost certainty due to Christmas and people not going to the doctor. So maybe we can ignore that bit. And then you might also know something about maybe ARI being seasonal. So could this be the beginning of a drop perhaps going into spring? And so do you adjust your model? Do you believe the same as before? Does your prediction change based on everything that I've told you, or maybe some other things that you know about ARI. In some ways, this represents different ways in which you could model this. And there are models for making predictions about infectious or about anything that just work on the basis of a time series and identify trends and seasonality and other things. And there are others, more kind of expert-informed models that you might want to use where you can put more of your assumptions in at the risk of introducing perhaps bias linked to the previous talk. Okay, I should probably show you what happened. So this, yeah, so does this match? Is this within your prediction interval? And then these are the next 3 weeks. Okay, now doing this exercise or using a model to make a prediction confronted to data, that is perhaps useful, but doesn't tell you all that much if you do it only in one instance. But if you do this repeatedly and many times, you can start building some evidence about whether the model and the uncertainty you express around the model is good or bad at making predictions. And you can think of this, it's a bit analogous to, if you think of something that we all know, the weather forecast. If you get a forecast that tomorrow, the probability of rain is 80%, and then whether it rains or not, it doesn't tell you all that much, because either way it's correct in a way. There's no certainty expressed there. But if you do it many, many times, then 80% of times you would expect it to rain if your model is correct. Okay, and so this is something that we started doing with work that we did for Ebola. So this is just one example of how you can do this over a longer time. So these are weekly forecasts, and you can see the data here as the thick black line, and then this thinner line with the dots and the uncertainty around it. These are 50 and 90% prediction intervals, are the predictions that were made the week before. And what you see here is that what sometimes happens, so here, for example, here's a drop in the data, but the model just extrapolated forward and predicted that this would happen. Yeah, so it was quite a long way off. And in this context, so you can do this, and you can say, you can start making statements about how correct or how good the models are, how wrong the models are, linking it back to my previous statement. And in this context, it's useful just to distinguish different types in which we make predictions in models, and that is to distinguish between forecasts and scenarios. So what I've talked about so far are forecasts in the sense of this is what we think will happen next. And this is assuming that all the uncertainty that you might have about the process and about what the future might hold, and of course there's always uncertainty about the future, that all this uncertainty is expressed in the interval that you give around the prediction. So your uncertainty is kind of a true, complete uncertainty. And this really only works in the relatively short term. So it only works when you make short-term forecasts. If you want to know anything for longer, what happens is that very quickly you realize you can't make very confident predictive statements about the future as such, or about how many cases of ARI there will be on the 15th of June 2026. And because of that, that makes these kind of models less useful for looking at things like longer term impact of interventions. And that's when we use scenarios, sometimes using the same kind of models, just running them for longer and constraining them in some way, sometimes using different types of models. But that's when we talk about scenarios or projections. So then these might be conditional on the scenario assumptions. So we constrain some things to pretend that we know them. We say, what happens if we introduce this vaccine or change this vaccine? And in fact, if you think about the earlier, when I talked about 2 different types of models and talked about the mental models, about knowing that it's ARI or not, if you are interested in studying the impact of rolling out or extending RSV vaccination or something like this, then the sort of time series model that just looks at the trend in the data that can't tell you anything. For that, you need a model that somehow builds in susceptibility and immunity, and what proportion of the ARI cases might be RSV, etc. So that's for those kind of projection models, you tend to need more expert-informed mechanistic models, whereas forecasts, with forecasts, you usually have access to a wider range of models. And we were together with the ECDC, the European Center for Disease Prevention and Control. We set up something that was called a forecast hub, part of the aim of which was to answer questions such as how far ahead can we trust the predictions from models, which types of models make the best forecasts, But also, so this was one, there was a research element to this, but it was also aimed to give reliable information to decision makers or to the ECDC in terms of what was most likely to happen next based on a range of models. So it's a platform where individual modeling teams or modelers could submit weekly forecasts, and then they would be displayed on a website, which looked like this, aggregated into what is called an ensemble model or a model average, but then also assessed, ranked, evaluated, ultimately also holding the modeling teams to account for their predictions and displaying the success of those. And this is based on, this wasn't necessarily our idea or ECDC's idea, this is based on longer term efforts that have been ongoing in the US and the CDC that have had an influenza platform for many, many years, since 2013, I think, as well as COVID-19 platforms at the time. And this here, for example, here you see one specific time point and then the forecast from different models going in all sorts of different directions, but then it can be useful to take an average, which usually gives something quite sensible. In fact, we did some analysis of this, and what we found, and in fact, what is a very well-known, by now well-established result that we see over and over again and have seen, and people have seen this in other fields even, is that ensemble, so an average of different models, tends to give you better results than a single model. So the uncertainty in the process is too much for a single model to give reliable forecasts, but by taking an average of multiple models, you get something better than that. So here, this is for all the countries that were part of this forecasting hub. And there's a score here. So this is comparing the forecast to the data, and you get a better score if your forecasts match the data better. In this case, the lower the better. The dashed line is a baseline model which just projects that things will stay the same. Okay, so the stars here are the ensemble model in each country, and the range are the individual models. And this is averaged over a long time period for cases and deaths, and you get a pretty consistent result that the star here is at the bottom of the distribution. Okay, so this is something positive. We've seen ensembles, we know, we learned something about how we make good forecasts. We need to take multiple different models and create an average from them to eliminate the bias from every individual model. So that's great. What was less positive is that we see that the forecasts were pretty bad in anything but the shortest time scales, or degraded pretty rapidly. And that's particularly the case for case forecasts. So here, broadly, a dashed line means you have a good forecast. So this is the 50% coverage. So that means the proportion of your future data points that are within the 50% prediction interval. Ideally, that should be 50%. You have the ensemble here in purple, and you just see pretty quickly you decline when you go beyond 1 week, both in the 50 and 95% prediction intervals. We also did some work on understanding whether, as I alluded to earlier, whether certain model types work better in making forecasts than others. And the results were pretty inconclusive. So I invite you here to focus on the blue, where 0 means no effect. So this is fitting. It's fitting a model to the scores that we estimated for the different models. But here, if you're to the left, you have a positive effect. To the right, you have a negative effect. You have some unadjusted scores, but here the bold ones are the key ones. And most things make no difference once you adjust for these factors between different models. The one thing that does make a little bit of a difference is that we saw some suggestion that models tended to make better forecasts if they were made by teams that focused on one country only. So again, maybe there's a positive message there that it helps to understand the data. This is all my interpretation. This might be wrong, but maybe it helps to have some understanding of the process in one country, to really focus on the data and do some detailed modeling on this, but the effect is pretty weak and not clear at all. Okay, so what we're saying is that it helps to create an ensemble from different models, but generally speaking, the forecasts of case numbers were pretty poor, or at least didn't reach very far ahead. We're reliable only in the short term. We don't have much of an understanding, or it doesn't seem to make much of a difference of how you do the model. So what is happening here? Why are the models not better at making forecasts? And one reason, of course, is that the COVID pandemic in particular was affected to a large degree by behavior changes, both in response to policy changes, but also beyond policy changes. And one good example of that is, so this is from the UK. You have the hospitalization numbers here at the top. You have in gray here the lockdowns. So we had 3 lockdowns in the UK. And at the bottom, we have observed, or not observed, but reported number of contacts by people in different age groups. So this is people who were asked in the last 24 hours, how many people have you been in contact with? How many people have you met? How many people have you had a contact with that amounts to a conversation? And here, for example, you could see that during lockdown, there was a certain number of contacts that people had, mostly in their households. And then once the lockdown was lifted in June 2020, behavior really took a long time to change. In fact, the largest change here you can see with schools reopening in September. Contacts between adults basically remained contacts of adults remained pretty low. And that wasn't necessarily something that was easy or possible to predict. And we certainly don't have good models of individuals' behavior that would allow us to predict that. I could go into, there's a lot more in these kind of behavioral data that I won't go into. In fact, or instead, what I will talk about is another study that we did where we thought, well, maybe the models are just bad, and maybe we can make better forecasts without models. So we set up a platform where people, and this ended up in the end being mostly us, but we invited lots of people to make forecasts by drawing a line on a plot on a graph. Yeah, and then, I mean, it wasn't the best, kind of most user-friendly platform in the world, and there's a whole interesting, I think, study to be done on how this kind of user interface would look. But anyway, you could do this. You can put in any numbers you want. You don't need to use a model. And we compared these to the forecasts from what ended up being 35 different models from the European Forecast Hub. And it turned out we actually did better than the ensemble in predicting cases. So here, this again, here lower is better. And you have the so-called crowd forecast, even if the crowd was sort of in the range of 5 people. And then the hub ensemble, and then another model that we threw in for comparison. And so maybe conclusion from that is that really there wasn't much in case forecasts that models ended up being good at. And maybe they just weren't particularly good predictors. And maybe, I mean, again, this is my interpretation, but maybe as humans, we are better at putting in contextual information or something that we understand about what's going on in terms of the political landscape and changes that are happening in people's behavior, then we can encode in models. Interestingly, the models were better than humans in predicting deaths. And this maybe indicates that there's something in the relationship between cases and deaths or hospitalizations and deaths. We have more reliable predictor, and what you really need to understand for predicting deaths is the statistical relationship between these different data streams. Maybe that's something that computers are better at. All of this on understanding our forecast during COVID. And I really don't mean to paint too negative a picture here, because if you think about the weather forecast, we're pretty happy to accept that beyond 3 days or so, you basically can't really trust it, or definitely can't trust it beyond 10 days. And maybe this is just about establishing a sensible horizon for how far ahead we can trust forecasts for infectious diseases. And maybe this is telling us kind of also in using these in policy or in decision making, this could be an important insight. I mentioned earlier scenarios, and I want to just briefly mention that not all models aim to make short-term predictions. It's only a pretty small part of what models can do, and often we make these longer-term scenarios. But even those scenarios, they do embed assumptions about the future, they do make prediction, and that opens them up for evaluation. And so this is just one particular instance where, again, I don't think it's worth going into a huge amount of detail, but these were scenarios, so maybe it's worth looking at the bottom here. So different vaccination scenarios, different NPI compliance scenarios, and in the US and in Europe, scenario hubs were also created, so similar to the forecasting hubs that I mentioned earlier, with multiple models, but looking at predictive scenarios. And you can do similar evaluations there. And there again, it turned out that, for example, ensembles perform best. Okay, so all of this on the wrongness of models, and that brings us to the other part of the George Box quote that I showed you earlier, which is that some models are useful, and the importance of understanding which ones or what it is that makes models useful. And one thing that's interesting perhaps in this context, that usefulness isn't the same as predictive accuracy. And so there's one particular quote here, for example, from the US Army Air Corps in the Second World War, working on the production of month-ahead weather forecasts. And there's just this quote that I'll give you. So the statisticians amongst us subjected these forecasts to verification, and they differed in no way from chance. The forecasters themselves were convinced and requested that the forecast be discontinued. The reply read approximately like this: the commanding general is well aware that the forecasts are no good. However, he needs them for planning purposes. So perhaps these were useful. And so I mentioned, it's much more difficult to establish utility than accuracy, because there's values attached to it, and there's kind of, there's the fact that they don't have to coincide. And but perhaps it's useful for us to try and study this systematically, and this is a project that we're doing in collaboration with Robert Koch Institute and the WHO Pandemic Hub, with some fantastic collaborators, several of whom are in the room. And as a first step, we did a scoping review of kind of this investigation of utility of the investigation of utility in infectious disease modeling, informing policy for outbreak response, finding that not much of this has been done systematically, and we don't really have any frameworks for, only few frameworks for assessing this utility. So we're trying to do more on this as part of this collaborative project. Okay, but so before concluding, I want to circle back to how I started and the kind of our work that we did early on during COVID, and that was based on a previous model on Ebola that was rewritten. And the fact that in these kind of outbreak situations, speed often matters, and it matters how quickly we can generate an analysis or a result. And there's a quote here from Chris Whitty, our chief medical officer in the UK, became chief medical officer in October 2019. So similar to Henrik's story earlier, I think had a bit of a baptism of fire through COVID, but has been in policy for a long time and in this kind of science policy interface. And in 2015, wrote a great paper on what makes scientific evidence useful for policy, and stating that an 80% right paper before a policy decision is made is worth 10 95% right papers afterwards. And in thinking about pandemic preparedness and preparing for the next epidemic, it's useful to think about how much of what we will need to do then, and how much analysis and modeling we'll need to do, can be predicted. And the fact that we were able to reuse a model that we used previously for a different disease suggests that this is the kind of thing that is probably useful in multiple contexts. But there will also be use cases that we can't predict that out, because every pandemic is different, or every epidemic is different. And there will be things that we can't predict. But if we can proactively develop general tools for the more predictable tasks, that would free up time for problems that require the more tailored approaches and domain knowledge. And I'll just give you a quick motivating example from another outbreak from Mpox. So this is a graph from a report on the Mpox outbreak in England from June 2022. And there we see something that we see over and over again in plots of case incidence, which is this drop towards the present. Yeah, so this is data by symptom onset, number of Mpox cases over time. It drops towards the present, and then there's a suspicious dashed line here. And what this dashed line is supposed to indicate is don't trust the data beyond that. And that is because there are delays in reporting. Yeah, so these ones here the publishers of this report suggested that these were still subject to further correction, whereas these here were deemed reliable. And so from this, it basically means don't interpret these case numbers to go down. They might still continue to go up, and we might see this in the final data. Now, this is something that we can correct for with models. We can do what is called nowcasting, and by learning from multiple snapshots of this, learning what the shape of the delay is, we can estimate with uncertainty what the final numbers here could look like. And in fact, this is what UKHSA later did and also published in the second article. This is a very common problem, and this is a predictable task, and this is what we should have well-developed tools set up that public health institutions around the world can use to apply to a situation like this. An unpredictable task for mpox was the importance of the transmission network. And you may remember early on in the mpox outbreak in 2022 was a surprise in that it was the first time that there was a large mpox outbreak outside of Africa. And it seemed to predominantly affect men who have sex with men. And there was a question of why that was. Was there an observation bias? And one question that we looked at was, can the patterns that we see in the UK at the time, can they be explained by differences observed and measured differences in the structure of the sexual network and the amount of sexual contact and the number of partners that people have? So this was data from a recurrent survey that's done in the UK from NatSal on number of sexual partners, and combining this with the data on mpox at the time. So again, combining different data sources via a model, we could show that the data that we observed at the time could be entirely explained by these differences in network structure. So if we distinguish between predictable and unpredictable tasks and think about creating tools for predictable tasks, then there are now multiple initiatives to create and disseminate tools for these predictable tasks. So there's things that we are part of, such as Epiverse and EpiNowcast. CDC launched a forecasting center for pandemics, and there's of course a WHO hub for pandemic and epidemic intelligence in Berlin, which is also supporting dissemination of these kind of tools for global use. And one of the things we're doing now, also as part of this Epiverse Trace project, is to further generalize this contact tracing tool that we created and apply it to H5N1 as a more up-to-date use case. So in summary, I think I hope to have shown that models aren't crystal balls, but used carefully, they can give us a glimpse of the near future and guide decision-making. I think it's really important that we evaluate both their accuracy and their real-world utility, but I think also there's a case for investing in modeling infrastructure that's flexible, reusable, and ready. And with that, I thank you for your attention. Thank my collaborators who were quoted on these slides. And if you want to follow up any of the links, you can look at the slides here.
Thank you very much, Sebastian, for this fantastic talk. So now again, we have questions. And online participants, please take time to write down your questions. So any question from our room? Yes, Julia, please.
Thanks a lot, Sebastian. Excellent talk. I was wondering, in terms of now more and more people are going to use AI to actually do the models. They will become more and more similar, and hence the ensemble model will be no longer of more use. And has there been, are you aware of kind of the prediction of those? I mean, the reasoning for the modelings as well, so that we can actually tease out which are the changes that are making the differences for the ensemble modeling.
Yeah, it's a good question. So some people have looked at it a little bit at how important diversity is for these kind of ensemble models, but I think that that's an active area of research and not very clear. And I don't know if it's true that AI is going to create more similar models, because arguably also AI could be used to create a range of models. So I think I'm not sure where I would land on whether this is necessarily a positive or a negative development. And one thing that is happening is that with these structures, so what I said earlier is that there's in creating models that incorporate epidemiological information, so-called mechanistic models, in creating them, there is a risk of introducing biases by how exactly we implement them. And one use of machine learning that I've seen is one where not necessarily modeling is based on more data, but on exploring more model structures and matching them to the data and having more flexible model structures, for example, in how behavior changes or something like this. So it's slightly deviating from your question on ensembles, but this is one way where I see AI maybe affecting how the modeling is done.
Thank you. Any question for our online participant, please?
Was the exactly same question.
So you have answered two questions.
If the artificial intelligence would be better at modeling than the humans. Yeah.
Sorry, the question is whether
if the AI could be better at modeling than humans.
Right. Maybe. I mean, you know, this is a bit like, what was it earlier? It was said that artificial intelligence is mimicking human behavior. Maybe. I mean, I think there's an interesting question there of whether. So we found that humans are better than models in predicting COVID-19 case counts, and it wasn't a staggeringly obvious result, but it came out as being better. So then, does that mean that human forecasts are optimal, or is this just that could we maybe create models that are better than humans? And it does, of course, depends on the context and the data availability, etc. And the data is a big limiting factor here, I think. But if we could find some leading indicators for some of these case counts and things that are being discussed are things like wastewater signals or signals from mobile phone data or something. If there's something that could be introduced in a model, then maybe those could do better than human forecasts. I mean, we obviously just looked at one particular case and also one where maybe models struggled particular, which is a new disease and not a seasonal disease or something. So, but not at the time anyway, but a new disease with new properties and where behavior and policy responses were somewhat unpredictable.
Now, thank you very much. Very fascinating talk. And this predictability brings me to a question. Now, the human brain does not work on a digital way, but neurons are working non-binary. And do you think that there could be data sets that are more easily or more precisely predicted by binary approaches rather than human approaches, or vice versa?
Yeah, I think so. And I think the weather is a good example. I mean, the weather is an example where we're probably pretty good at forecasting the weather, but the models are even better. So because as humans, our best prediction is there's going to be something like this, and then depending on the season in which we're in, it's going to broadly go up or down. But one thing that all the models have struggled with is predicting changes in trend. And this is something where I think we can have predictions from weather forecasts that we wouldn't have expected as humans based on our intuition and our behavior, or based on our intuition and our observations. And I think that has just never happened at least not during COVID. So I would say we have a very striking example of something where a binary approach works better than our intuition. But I think the problem is that in infectious diseases, we just don't have the resolution, temporal and spatial resolution of very accurate data. This is me now falling into the classical modeler's trap of blaming the data on the failures of my models. But I think that may play a role in the fact that we just can't make very good predictions even with models. Yeah, well, maybe maybe contextual information and maybe a kind of an understanding of the process that is difficult to encode in a physical model. Maybe that plays a role there, but that's pure speculation. That's my interpretation of things. Might be something else.
Further questions?
There's also, I mean, well, going just following up on that. I mean, so a few things are. We have no guarantee that the humans who submitted, apart from maybe the people that I spoke to myself, that they didn't use a model, right? I mean, so who knows? And the other thing is that, I mean, one of the things that I did when participating is put things on a log plot. Now, arguably, that's also not a very human way of processing information. And I use the transformation of the data to inform the way I'm out of this. So it's also, whether this was entirely human intuition or whether it was to some degree aided by computers is another question there.
Denise, go ahead.
Thank you. Really nice talk. So I guess from your ensembles result, the new quote will now be all models are wrong, but together they are useful. But I'm wondering, what do you make out of this? So when the next pandemic hits, which I hope is a long, long time from now, how do you go about dealing with it? Like, how do you now develop these like reusable tools for predictable tasks? Like, do you go for lots of ensembles, or do you want to try to find a way to still be able to distinguish in like a new unseen like outbreak situation, like what model could be most useful?
Yeah, I think it's a really good and important question. I think the fact that ensembles make the best forecasts doesn't necessarily mean that there's no role for individual models, because what you lose in an ensemble is the interpretability. So you don't necessarily know why it behaves in a certain way. I think, thinking about the future, I think it's the ensemble insight is a useful one because it motivates having multiple models. So, and something that people are thinking about now, for example, is the idea of micro hubs. So having a forecast hub not composed of different people making models and putting them all together, but creating some models in advance that can form the basis of an ensemble, and then maybe you could add some contributions to that are more specific to a new disease or something. But also, I think this is looking at the specific issue of prediction. I think one thing that we've learned during COVID is that it's generally useful to have multiple models, even when you look at them in isolation, just to get a better understanding of potential uncertainties and biases. And from having multiple models pointing in different directions, it kind of affects your confidence compared to just having one model. But I think thinking about the future, the main insight is useful having multiple models. If you want the most accurate prediction, then creating an ensemble is probably your best bet, but there are other things for which you might want to have the individual models.
Other questions? Otherwise, I also have one. Sebastian, you mentioned that you can, using the nowcasting, you can correct the reporting delay behavior. And I'm wondering, where do you get the reference data to do this modeling?
Yeah, so the reference data could either be the underlying kind of individual level data, where you have individual onset dates with their reporting dates, and just by aggregating those, you get some kind of distribution of delays that you can use with the models. Or you could, if the other way of reconstructing this is from multiple snapshots of the same data. So there's actually, I mean, so I just mentioned individual level data, but this can be done in a totally anonymized, de-identifiable way. All you would need is to know, what does this kind of plot look like at different times, and from this you can reconstruct the kind of delays that are in there. So it's you don't need any external data, you just need this kind of data, but snapshotted on different days.
Thank you very much. So, thank you very much,
Thank you,
Sebastian, for your wonderful talk. And you also get a from us. And this is less than €5, don't worry. Okay, dear colleagues, we're coming to the close of day one, and on behalf of the organizing committee of the Robert Koch Colloquium, I would like to thank you all for being here in the room, and being here online. So we also thank all the speakers of the day, and thank you for joining us. Thank you for all your questions, all your good thoughts, and good collaboration and communication. So please be sure to join us tomorrow at 9 a.m. So we will start at 9 a.m. and we will begin with a short snapshot of today. Francie will give us a short overview at the beginning. So please be on time. And for people from external, not AKI workers, please come a little bit earlier because you need to go through this security check again. So let's see what did I forget everything? Okay, yes. Now it's time for a small reception. So you will find it in your foyer, and there are some small refreshments for all of you. So thank you very much for today, and we see each other at 9 a.m. tomorrow morning. Thank you.